Dr. Ashish Bhala, Dr. Shrikant, very good morning to you. If you can hear me, please accept the request being sent to you to be promoted as panelist on Zoom link. Please accept the request, sir. Who is joined by the name of Kamal Kumar? Who's Hall E? Hall E, can you please unmute yourself?
Hello.
Good morning, Dr. Ajit. Very good morning to you.
So Dr. Rajesh Pandey is going to join, is it? I mean, yeah.
Yeah, Dr. Rajesh Pandey would be joining in.
Oh, okay. Yeah.
Yeah. Dr. Shrikant, if you can hear me, I'm pushing a request for you to be promoted as panelist. Please accept that. Okay, you did.
Yeah, bolo.
No,
Hi,
sir.
Ajit.
Yeah. Now you are on the panel, sir.
Yeah. So
Hi, Srikanth.
hi, Ajit. How are you?
Good, great. Thanks.
Yeah. So, madam, what is the problem is that we have to still be live, even if it is recorded.
No, so you will not be live, sir. You would be taken live, and there's the question and answers.
During the question, but this is the panel discussion, means it is a question and answers.
Yeah,
So,
I know. But after the panel discussion, in case if we receive any question, we'll be putting that across to you. So we have our hall anchors also who would be doing the needful. Yeah.
Okay.
Who's hall E? Who's here by the name of Hall E? Please introduce yourself.
DR underscore. छोटा है वो. एक मिनट. क्यों ऐसा? मोबाइल इधर ही रहने दे भाई.
Recording in progress.
ये बंद करो. Yeah, madam, I have logged in through my kind of laptop. So I will shut off my mobile there. Join next time.
Very good morning to you, Dr. Pandey.
Yeah, good morning.
Good morning, sir. So we have with us Dr. Nida here, who's the anchor for Hall E, and she's going to brief you about the CVs and all, and then we start off with a session.
Sure.
Panel discussion. All the very best, everyone.
Thank you.
Hello, should I start now?
Yeah, please do.
Okay. Good morning, everyone. I welcome you all for the World Conference COVID and Critical Care. Let us start with the panel discussion on interpretation of lab diagnostic tests and prognostic markers in COVID. Our moderator is Dr. Rajesh Pandey, Senior Director and HOD Critical Care, BL Kapoor Super Specialty Hospital, New Delhi. Now I would like to request Dr. Rajesh Pandey to introduce our speakers, panelists.
Well, we have a galaxy of stars who are participating in this discussion. So we have Dr. Ajit Kumar AK from Manipal Hospital, Bangalore. And we have Dr. Shrikant Shahasbude, a senior intensivist and a respiratory physician from Aurangabad. We have Dr. Ashish Bhalla, who is a senior professor of internal medicine at the PGI-MER, Chandigarh. And we have Dr. Rashmi Kapoor, who is a senior pediatric intensivist at the Regency Hospital, Kanpur. And we have Dr. Satoru Hashimoto, who is an intensivist and professor of critical care in Japan. And we also have Dr. Prashant Kumar, who is a senior physician and a professor in anesthesiology and critical care at the prestigious Pandit B.D. Sharma PGI-MER, Rohtak. So I welcome all the eminent physicians on this panel. I think you can start the proceedings now. Nida, you can start the proceedings now.
Good morning, ladies and gentlemen. So we have a discussion now. It's a great panel of eminent people that I have with me. And we'll be talking about interpretation of lab diagnostic tests and prognostic markers in COVID. What has been our experience with the first and the second surge. I am Dr. Rajesh Pandey. I am the Senior Director and Head of Critical Care at BLK Max Super Specialty Hospital. And the panelists with me are Dr. Ajit Kumar A.K. Nair, who is a Senior Intensivist and a very important member of the Indian Society of Critical Care Medicine. Ajit is a consultant in intensive care at Manipal Hospital, Bangalore. And we are also joined by Dr. Rashmi Kapoor. Dr. Rashmi is a senior physician. She is a director in HOD, Department of Pediatric Critical Care and Respiratory Medicine, Regency Hospital, Kanpur. We also have with us Dr. Shrikant Shahasbude, who is an eminent physician from Aurangabad. He is the director and head, Department of Critical Care Medicine at Medicover Hospital, Aurangabad. He's an ISCCM teacher also, and he's a great tabla player also. And we have Dr. Prashant Kumar, who is MD, PDFNA in neuroanesthesia and critical care. He also holds a degree in hospital administration, and he has been a Commonwealth Fellow in UK. He is at present professor in the Department of Anesthesiology and Intensive Care at Pandit B.D. Sharma PGIMS at Rohtak. We also have with us Dr. Ashish Bhalla, who is a professor of medicine in the Department of Internal Medicine at the prestigious PGI-MER, Chandigarh. Ashish has more than 350 publications to his credit and is very active in ISCCM as well as in emergency medicine. We also have with us Professor Satoru Hashimoto from Japan. Dr. Hashimoto is the Director of Intensive Care Medicine at the University Hospital of Kyoto, Prefectural University of Medicine. He is an intensivist and also contributes to hospital information and technology. At present, he's also organizing GIPAD, which is Japanese Intensive Care Patient Database, which is part of the Japanese Intensive Care Society project. So he's the project leader here. So important man in Japan. So with this introduction of the eminent panelists that we have with us, I'll just introduce the subject. So I have a couple of slides before we begin the panel discussion. So this is one patient story that I have shown here because we are talking about inflammatory markers. So you can see this is a journey from 15th May this year to 1st June. And to begin with, the patient was on high NIV support, 100% oxygen. He was tachypnic, condition was pretty bad. And then gradually over a period of 2 weeks, the patient became better. And when the last biomarkers were taken, he was on NRBM and he was COVID negative. He was stable. And you can see the changes. You can't make out much except that D-dimer were very high here. All the markers were high. Ferritin D-dimer were quite high. And when the patient started settling down, we found the D-dimer were coming down, consistently coming down. But again, ferritin is unusually high here. Absolute lymphocyte count remained low throughout. So when we go back to the basics of, what is happening in COVID-19 disease, we know there is a spike protein here, as you can see it here, surface glycoprotein S, which is in the COVID virus. It binds to ACE2. And in the renin-angiotensin system, the renin converts angiotensinogen to angiotensin 1, and then ACE2 converts angiotensin 1 to 2. Angiotensin 2 that is formed has a dual role. It works through the angiotensin 2 type 1 receptors as well as type 2 receptors. With type 1 receptors, it causes vasoconstriction, fibrotic remodeling, and inflammation. With type 2 receptors, it causes vasodilation and growth inhibition. This angiotensin 2 is further cleaved by ACE2 to a group of angiotensins 1 to 7, which counteract the harmful effect of ACE, angiotensin 2, and AT1 excess. And ACE2, as we know, is present in distal airways, in the alveoli, particularly type 2 pneumocytes. And we know type 2 pneumocytes also have the highest expression of alveolar macrophages and dendritic cells. And this is also found in vascular endothelium, then nasal, oral, nasopharyngeal, oropharyngeal epithelia. This is there in the gut epithelium, cardiac pericytes, skin, CNS, reticuloendothelial systems. And the expression depends on age, genetic factors, presence of comorbid conditions, use of immunosuppressive drugs. ACE2 is downregulated and angiotensin 2 is upregulated. So this cartoon shows you what is actually happening here. So you see the binding of inhaled SARS-CoV-2 to the ciliated secretory cells in the nasal epithelium occurs via ACE2. The viral replicates. There is local propagation with a limited immune response. Either it can be contained. For example, in 80% of the patient in 10 to 14 days, there is viral clearance and they improve, or this will continue to involve the conducting airways, upper respiratory tract, and migrate into the lower respiratory tract in about 1/5 of the patients. And finally, there is invasion and infection of type 2 pneumocytes via ACE2. And then it can, the viral will continue to replicate and will release viral particles with resulting apoptosis of the host cells. At the same time, it precipitates something like a cytokine storm by releasing the cytokines where IL-6 is believed to be a major culprit, but a host of other cytokines, inflammatory markers, including TNF-alpha, GM-CSF are released. They act as chemoattraction for neutrophils, CD4, CD8 cells, along with the B cell differentiation, and the continuing viral replication infection causes infection of the adjacent healthy alveolar cells with loss of both type 2 and type 1 pneumocytes. All these inflammatory cells, when they come into the picture, there is sequestration of these inflammatory cells in the lung tissue with CD8 mediated cytotoxicity as well as lung injury. So the host defense and attempt of viral clearance, generally when it fails, we find diffuse alveolar damage with, resultant acute respiratory distress syndrome or ARDS. So this is in a nutshell what happens in the patients who progress. 1/5 of all patients who will progress to frank ARDS. So with this brief discussion, I move on to the first question, and my question is to my friend, Dr. Ajit. Ajit, what biomarkers are involved in COVID-19 that you have seen in first surge and the second surge? What has been your experience?
So biomarkers, before I go to the biomarkers in COVID, just want to mention a few lines about biomarkers. See, biomarkers are substances which are objectively measured, which can be used to monitor, assess the pathological, biological processes, and even the therapeutic response. So the thing is that in COVID is not a disease which is just confined to respiratory system. It's a systemic disorder where there's a complex interaction between the various various inflammatory, immunological, and the coagulatory cascades are involved. So the importance of biomarkers in COVID, maybe for early suspicion or diagnosis. Once it is diagnosed, whether we'll be able to triage the right patient and the right type of care, the patients which require intensive care, other ward care, etc., and maybe very important for determining the type of treatment what we are planning to give. And obviously, finally, it is very important that we should be able to predict the severity of the disease the patient is likely to have in a particular group of cohort of the type of patients. And finally, the response to the therapeutic agents. These are the importance of biomarkers which we expect, the ideal biomarkers, which is we expect in COVID. So COVID-19, we have innumerable. I will say there's a big list of biomarkers are there. Practically, we can divide generally into around 6 categories. One is about hematological biomarkers. For example, you can have leukocytosis, leukopenia. Obviously, many other biomarkers are very non-specific. I'm just coming to that. These hematological biomarkers can be leukopenia, leukocytosis, thrombocytoma, even thrombocytosis. Here, one thing is that the neutrophilia is expected in COVID, and there is significant lymphopenia in many patients. So basically, what happens, the neutrophil lymphocyte ratio will be definitely high in COVID. That is a hematological biomarker. The inflammatory biomarkers, we all know it is about the CRP. CRP is inflammatory biomarkers, LDH, ferritin, these are, and procalcitonin, they are, even, markers of the severe inflammation, which is very important because some of these biomarkers can predict, which patient is going to be very severe in the disease. And coming to the coagulation, we know that, COVID is a prothrombotic disease, and we know that, we all measure D-dimer, in COVID cases, and obviously other FDPs and, other, APTT and PT are all measured. Coming to the other biomarkers, apart from this, you have the cardiac biomarkers and hepatic biomarkers and some kind of electrolytes, which I'm not going to read details of that. So in India, we had a very recent, for the pragmatic purposes, we had a very recent guideline which has been issued jointly by the All India Institute of Medical Science and the Ministry of Family Welfare, Ministry of Family Welfare, and the All India Institute of Medical Science. For the pragmatic purposes, we know that most of the biomarkers are non-specific as well. And obviously, which I mentioned, the one thing which I mentioned, the inflammation was the cytokines, which my apology for that. Cytokines will also come under the inflammatory biomarkers. The Ministry of Health and Family Welfare and the All India Institute of Medical Science and the AIMS has made a joint task force. They made a recommendation that in Indian patients, for the Indian patients who are in the ICU, these the CRP, the CRP and D-dimer are the biomarkers. These patients, which in the ICU patient we can monitor every 24 to 48 hours. And the CRP and the D-dimer and the ward patient maybe every 72 hours. That is what they told. And the interleukin 6 is measured only those patients who are deteriorating. So what I mean to say that for the Indian perspective, these are the 3 biomarkers which has been joined by the joint task force which has recommended: the CRP, the CRP, D-dimer, and the interleukin 6. So that is what it is. I'm not able to hear, sir.
Sir, you are muted, sir.
Yeah.
So building the discussion further, I have an open question, just taking it forward from where, Ajit left, that ICMR and AIMS task force. Now, which in your opinion, now we have been through both the surges, are the most sensitive or specific biomarkers for assessing severity in COVID-19? Because like he said that ICMR AIMS panel recommended that IL-6 should be kept reserved for only, yes, only those cases and patients who are deteriorating, worsening, and routinely they recommended D-dimer and CRP. So what is the opinion?
So in my practice, apart from the CRP, D-dimer, interleukin-6, we also do LDH and ferritin as well. The practice what we are following here is that when at least two of the parameters, I will say two of the parameters are more than 10 times, going more than 10 times the normal, we try to initiate immunomodulator therapies. And especially when we are sure that the patient is not having active infection. What I mean to say is that we try to assume that the patient is deteriorating, the oxygenation is worsening because of the cytokine storm. And cytokine storm, when these inflammatory markers are really going high, at least two of them are really going, whichever the inflammatory marker which I mentioned to you, the battery of the interleukins, the D-dimer, CRP, ferritin, LDH, and interleukin-6 are definitely going high. At least two of them are going more than 10 times. And we believe that the patient is not having active infection, which we try to indirectly assess by, again, it is not 100% sensitive. We do procalcitonin for the patients. And we are also clinically very sure that the patient is extremely unlikely to have a secondary infection. These are the patients when we choose for, immunomodulator therapy, apart from the standard therapy with, the steroids and, the dexamethasone therapy. Yes, that's what I wanted to do.
Dr. Prashant, Dr. Shrikant, Rashmi Madam, would you like to add something more to it? What is your opinion in this regard?
Dr. Ajit has covered all the things what practically are needed. And I also believe, and what we have practiced, that we need to have a tier system for investigations in terms of biomarkers. It may not be justified for jumping all the biomarkers which are available as a research method or practically for prognostication also. So initially when the patient comes in the mild to moderate or just admitted in the ICU also, having a CBC, CRP, electrolyte, LFT should suffice. And if the patient has deterioration and we need to go further, then we need to look for the secondary biomarkers and we can plan for that. So the entire system for biomarkers is a practical approach to all the patients which are received in hospital.
Yeah, even I agree to that. And in fact, I am a pediatrician and I worked in a non-COVID hospital, but we all, as we were too interested to read up all about IL-6 and things. So initially what had happened was IL-6 was not available. And then we were thinking we are missing out on something. But when IL-6 kit became available, then we found that, it was sort of, we didn't know how to judge about it. So, and it was a very, very expensive investigation. So I guess as our government has issued the guidelines, we must stick to them because every place has their own guidelines and should have their guidelines. Everything that can be done should not be done. So IL-6 is a good marker, and but it should be reserved for very serious, severely affected patients.
Dr. Shrikant?
Yeah, even I believe that limited biomarkers at a proper time with proper interpretation of the values, as Ajit and Dr. Prashant has said. Just for an example, that we know that after therapy also the IL-6 goes up. So a proper interpretation of increasing IL-6 along with the correlation of the clinical condition would definitely help us.
I think this is, a great piece of information to the viewers that we do not need to jump, and do everything nearly, every day. It has to be done in a graded manner, as the, eminent panel has suggested. And also, like Dr. Shrikant said, that we have to look at the clinical picture also. Because every day, if we are doing these tests, then it is very difficult to explain. Then the family starts talking in terms of numbers. Why the numbers are so high? Yesterday also this was, or this is, a bit high. So it's difficult. So it has to be also related to the clinically correlated to the patient's condition. So moving on from here, Dr. Rashmi, because we have seen a trend that absolute this neutrophil count, lymphocyte count has been low. So what is your opinion in terms of this in COVID-19?
So in COVID-19, actually neutrophils are raised more. That is the reason NLR becomes distorted than what we expect. Actually, neutrophils actually are the most abundant immune cells in our body. And we know that they play an active role in killing of bacteria and fungi by phagocytosis and degranulation. But they also have, it was like recently it came into many researchers found that I think around since 2004, the other roles of neutrophils have also been found, like it enhances antiviral defenses by interaction with other immune cells, virus internalization and killing, cytokine release, oxidative burst, degranulation, and neutrophil extracellular traps that are known as NETs. Now, this was a new term which came in the being in 2004 only. And NETs are actually specialized network of DNA with the web-like structure of nucleic acids. They are wrapped with histones and detain the viruses. And the process of producing NET is known as NETiosis. Now, NETiosis is a control process. It can actually protect the host, but if it is dysregulated, it can cause hyperinflammation by neutrophil elastase and amylose peroxidase. Now, neutrophils, it was very interesting to read about it also, that neutrophils have a major role to play in inflammation in COVID-19. So neutrophils, NETs, and endolithiasis and endotheliitis, neutrophils, NETs, and procoagulation response, neutrophils, NETs, and lung damage, neutrophils, NETs, and kidney damage, neutrophil, NETs, and Kawasaki disease, and so on and so forth. So everything was generally caused by neutrophils only. So they play a very, very important role. In fact, what happens in lungs is after the virus reaches the alveoli, it triggers an innate response and it attracts the neutrophils. And this neutrophils, they then secrete all these cytokines and NETs and cause the pro-inflammatory process. So that way, I think knowing that neutrophils have a major role to play, we can also target a therapy towards neutrophils. And NLR has been a big marker. They said that NLR more than 3.5 and age more than 50, then it has a bad prognostic values. So NLR was actually used as the prognostication of the COVID-19 disease itself.
So, Dr. Prashant, NLR versus absolute lymphocyte count, we saw lymphopenia in majority of the patients here. And as they would recover, we found that the lymphocyte count would start rising again. So, what is your take on this? What was your experience?
This is true. This is the trend worldwide, which has been reported. And this is, when we start looking from the biomarkers, as Dr. Ajit started, the first biomarker he also quoted was that we should look for the counts and lymphocytes and neutrophils. So probably the most significant thing which has been seen with the adults and which also gets translated to children is the lymphocytopenia. And lymphocytopenic mechanism, Madam has already talked about various mechanisms. There are three things which has been reported or speculated with the research, that it is due to the ACE2 receptor on the lymphocytes. It is either the direct viral invasion or lymphocyte apoptosis, or it is because of the cytokine storm which the lymphocytes get. So lymphocytes definitely initially when the viral load is there and they gets damaged due to the apoptosis or the viral invasion, we do lose lymphocytes. But at the later stage, as the viral invasion goes down, the viral load goes down of the body, the total leukocytosis is seen. So that is how the NLR ratio also changes. And that is how the role of CBC comes as the most important biomarker to me for the management and prognosis of all the patients who are coming to hospital.
Thank you. I think this clearly answers tackles the issue. So my next question, Dr. Prashant, and of course, Dr. Rashmi is a pediatric intensivist, so she can also join here. Is there any difference in biomarkers between adults and children, or it's the same trend that you see in kids also?
So it's the same trend. It's the same trend. We saw very little number of very severe COVID affected children, but we saw a lot of MISC. And in MISC also, we find a lot of these inflammatory biomarkers and coagulation biomarkers to go sky high, and the cardiac biomarkers. So, and they are the same.
So essentially it is same. The pathophysiology, the response, and the biomarkers are same.
Absolutely. In fact, that is why I say I emphasized on neutrophilia, because it is neutrophilia and leukopenia. So why neutrophil came as an important, lymphocytes will come down, but neutrophils are increased because they have a role to play in. So early in the disease, we find that lymphocytes go down and neutrophils increase. And they are all because of these mechanisms.
Thank you.
Very rightly, Madam has summarized it in one line that not much difference has been observed till now in the pediatric and the adult group. And pediatric also, the lymphocytopenia and CRP going up. And in electrolyte biomarkers, hyponatremia and LFT, liver enzymes getting deranged. These are the common things which has been observed. And when on the second tier getting investigated, the same IL-6 and LDH, they also have been seen to go up.
Now, talking about the therapeutic modalities available, remdesivir and toci was used quite extensively. So my question, Dr. Rashmi Kapoor, to you as well as to the rest of the panel is, what is the impact that you have seen in your clinical practice of using tocilizumab on biomarkers in COVID-19?
So I have personally very little experience of using tocilizumab, but we know that IL-6 and GM-CSF are the key cytokines which lead to the inflammatory storms. So anything targeting these things would be benefited. So there have been several studies. You know, initially it was said that tocilizumab is excellent. So people started during the first wave, people started giving tocilizumab quite a lot. Then there came the reports. There were many studies which said that tocilizumab was of no use. Then again, there were several reports saying that tocilizumab is a very good drug. And we know that IL-6 has two forms. One is membrane bound and the other is soluble. And tocilizumab actually binds to the soluble one, if we give which is an IL-6 receptor antagonist. Now, when there was a very good study by H. Zhu and Han, etc., which was published in 2020, that when they gave tocilizumab to patients who were, not on ventilator before, but they were severely ill, their biomarkers were going very high. So in 21 patients, they tried tocilizumab, and then they found that WBC increased. We know there is leukopenia as well. So WBC increased on day 1. It started reducing by day 3 and came down to normal by day 5. Then lymphocyte percentage decreased further on day 1 and started increasing on day 3 after giving tocilizumab. CRP started coming down from day 1 after giving tocilizumab in children, and procalcitonin also started falling from day 1. There was generally no effect in first 2-3 days on D-dimer, and it kept on rising, or it remained stable. It did not come down. IL-6 came down a little bit on day one, but subsequently increased, because we are blocking the receptors of IL-6, and that is the reason for first few days the IL-6 goes higher. And it should not misguide people that IL-6 is going high, so it's not being very effective. We just have to monitor it regularly to see when eventually it will come down, when all the IL-6 has been exhausted, because the viral disease is gone and the inflammatory storm is gone. So these were the effects, and there were several studies to quote this.
Yeah, thank you. And because we need to know how the biomarkers evolve before we use these, drugs and other therapeutic options. So my question to Dr. Shrikant is, what is the relation between evolution of COVID-19 and the biomarkers? How, at what stage we see which biomarkers, rising in the COVID-19 patients? Dr. Shrikant, please unmute yourself.
Yeah, now I'm audible.
Yeah.
I'm audible? Yeah.
Oh, you're looking smart. You're fully audible.
Thank you, sir. And thanks for the kind words and the compliments. And it's always a pleasure to be with you. So just taking forward your question, and a few things which I just said, and a few of our friends already had touched upon, is you have various biomarkers which we do, and there are a lot of the exhaustive list of what we can do, including the CRPs, ferritins, D dimers, and the IL-6, along with the other IL like IL-4 or IL-10. But I think let us go back to the NL ratio again, where it is said that the low lymphocyte at the beginning carries a poor prognosis. I'm sure many of us, as Dr. Prashant as well as Ajit said about the NLR and the significance of low lymphocytes, and it has been actually given in the literature that if it is low at the beginning, it carries the poor prognosis. So naturally, if the NLR is high right from the beginning, we are actually encountering a patient which is not well. So talking about a few other very commonly done biomarkers in the process of the COVID-19, as far as the evolution of the disease is concerned, as we know that CRP, if it is rapidly increasing, if it is high and rapidly increasing, it will suggest a secondary infection. So we have to be very careful whether we are seeing a cytokine storm or we are seeing something else, because the therapy would depend upon that. The same thing is probably with D dimers, that if you see a D dimer of more than 1 milligram per ml at any point of time, it carries a very, very poor prognosis. And I'm sure everyone will agree that it is quoted that it would have about 18-fold increase in the mortality rate, along with the few cutoffs which has been given. And for the sake of theoretical purposes, I'm just quoting it for the advantage of everyone who is listening, is that if it is more than 2,600 nanograms, it is, or if it is 10 times the normal, we are bound to see the other complications which are usually seen with COVID-19, like coagulopathy. So it is said that if it is more than 2,600, it demands the Doppler studies to rule out any thrombotic episodes in the body. So this is just about a few of the biomarkers, along with the CRPs and D dimers, as we see the IL-6, which tells us about the progress of the disease, or the happening of a cytokine storm, which is the very probably the dreaded complication of COVID-19. And we have a IL-6 at any point of time, which is more than 10 times. That was the earlier studies which quoted about the as regards the indication for tocilizumab in this patient. But the recent Lancet paper, which talks about a hypoxia and a CRP, which should be more than 75 as what is quoted in the paper. So essentially, these biomarkers would obviously help us in evaluation of the disease process and the progress, along with the severity and the criticality, and at the time which is done, again to correlate with clinically. And I'll again re-emphasize about correlation of these biomarkers with the clinical scenario. and of course helps us in treating the patient in terms of different treatment modalities. And just to kind of have a little more comprehensive kind of picture with these different biomarkers, and you would find this in the guidelines stated by our Ministry of Health and Family Welfare about the mild, the moderate, and the severe disease, and the correlation of these biomarkers and the values which have been quoted. So just to give an example, you have CRPs of less than 40 in mild, and which goes above 100 or 125 in a severe disease. The same thing is with ferritin, which is seen as less than 500 in mild cases, and which goes above 800 in severe cases. So when the ferritin is going high, we need to actually be very careful again to have any alternative possibility, like which has been quoted as secondary HLH, if the ferritin is very high. So we have to be cautious about the other things, along with the IL-6, which I actually said, and the D-dimer, which is actually said that you have a high D-dimer, you are actually seeing a bad patient, and the possibility of coagulopathy in this particular patient. And there was a study which showed that in terms of treatment strategies, if we actually give oral anticoagulation to this patient, just because the D-dimer was high, actually doesn't have any effect on mortality or having the treating the coagulation problems. In fact, it can increase the risk. So all in all, I think we need to be very careful of interpreting the biomarkers when the evolution of the disease happens. And just to kind of throw a light on procalcitonin, classically it is said that the procalcitonin may not go high in COVID-19, and we need to be actually careful about interpretation of procalcitonin in COVID-19.
I agree with you, Dr. Shrikant, and many of these markers are actually acute phase reactants. So whether we need to really bother about them or to look at the pathophysiology of the disease is a big question which is still unanswered. So coming to the end of the discussion, I have two questions related addressed to Dr. Ajit and Dr. Prashant. This is now the role of biomarkers. Dr. Ajit, should we follow biomarkers in post-COVID-19 discharge patients, as we do for those who are admitted with active COVID?
So, based on the current available evidence, so there is no concrete evidence or recommendation that we need to follow the biomarkers in the patients, COVID patients post-discharge. But having said that, I just came to know some interesting, I will say it's an expert opinion. Again, the evidence is weak actually. So which was, I think, in the April 2021, there's BMJ, the postgraduate education BMJ, that the people, what happened was, because there's an increased pro-thrombotic tendency in COVID-19 patients. So what they did was, they were deciding about the anticoagulation, whether we need to anticoagulate the patients or not. In that guideline, or whatever the suggestion, again, it's not a concrete thing. In one of the things is that they were in to assess the risk for thromboembolism, they were making something called the modified improved risk score for venous thromboembolism was utilized. So where they were mentioning that when the modified improved risk for venous thromboembolism is more than 4, or the modified improved risk score is more than 2, and the D-dimer is more than 2 times upper limit of normal, or age more than 75 years of age. These are the patients where they are, as an expert opinion, they are telling these patients may require 30 to 45 days of prophylaxis can be given. What I mean to say is that one usefulness of maybe the D-dimer at discharge, which I just come across, obviously based on my knowledge at this point in time, there is no concrete evidence that there is any role of any of the biomarkers at discharge or follow-up of his COVID patients.
We understand. Thank you, Dr. Ajit. So that's why the next question is to Dr. Prashant. As you guys are running your long COVID or post-COVID clinics also, which is a follow-up clinic where RT-PCR negative recovered patients come. So do you feel that, are you doing any biomarkers, or you feel that we still need to do in long COVID patients also, look at the biomarkers?
Sir, I will speak more from the personal experience rather than evidence what we have. When we started getting long COVID patients initially, it was difficult for us and the patient to believe that they still have the effect of the COVID left. And the patient presented with the varied symptoms of myalgias, low-grade fever continuing. Then there were reports of patients coming with they used to say that we have lightheadedness and there is forgetfulness, which was coming the easiest thing for the patient to say. Later on, it has been labeled as brain fog also. So these patients, when we started looking for these patients, investigating in cases of biomarkers, what I would say that even when the hematological parameters were improving or touching the normal range, it was observed that their CRP and IL-6 were raised. And then as the case series have come up and the reports from across the globe is coming up, not only IL-6, IL-4 and other interleukins are also coming up, which have been found raised in the patients who are coming with long COVID. So what I suggest and what we are also doing is that if the patient is post-COVID presenting with varied variety of symptoms, which can be anything from myalgias, arthralgias, amnesia, or people are having brain fog. And these patients, if they present with is typical symptom which can be fit in the post-COVID thing and the correlated, we do not need to go and try to correlate with the biomarkers for the prognostication or anything. But what is needed, if we have any doubt and the patient's COVID history is, say patient was asymptomatic kind of thing and doesn't believe, and then land him in long COVID or the secondary COVID effects, then if we want to do the biomarkers, yes, CRP, LDH, D-dimer, IL-6, and research says even IL-4, they are coming raised to the patients in post-COVID. But we are not requiring it to diagnose and treat the patients.
Thank you. So it clearly tells us that, routine patients who are coming to the long COVID clinics in the outdoor, we don't need to go for any of the biomarkers, but for patients who become sick again, who come back to the ICU after they have been discharged and have been home for 2 or 3 weeks, there possibly we need to look at the inflammatory markers again. And like Dr. Ajit has said that, those who are more susceptible, high risk group, maybe we need to look at the process of thrombosis and maybe do D-dimer and other things. So as such, there is no absolute role here. No. Thank you very much. I would like to thank all the panelists for this very interesting discussion and sharing their knowledge with the viewers.
Thank you very much.
Thank you, sir.
Thank you. Thanks.
My question to you, Dr. Ashish, is, so much has been spoken about biomarkers by the previous speakers. So what is the role of biomarkers in the management of COVID-19?
Dr. Pandey, this is a very, very interesting question. The most important thing for us to realize is that there is no one specific biomarker for COVID infection. But there are indirect biomarkers which have been used to treat the hyperinflammatory response or the cytokine storm, or to predict which are the patients who are likely to go into cytokine storm at a later date. And most of these markers are markers of inflammation. Of them, couple of them which are important. One is CRP, that is C-reactive protein. Other is the ferritin level. And the third is, most important one, is the interleukin-6 levels. Out of them, I think the most important and the one which has stood the test of time is the CRP, or the C-reactive protein, which has been over the period of time studied in various research projects. And what we've come to know is that anyone who has a rapidly rising CRP and a CRP level which is gone above 75 is kind of a marker for it's a marker for a patient going into cytokine storm. And what we've seen is that if we decide the therapy with tocilizumab, that is the IL-6 receptor blocker, based on this parameter, we found very good results. Interleukin-6 levels are expensive, not readily available, and they change rapidly once we administer interleukin receptor blockers, that is IL-6 blockers, that is tocilizumab. So may not help too much. Ferritin is a non-specific marker, which again does not definitely help very much. One of the markers which indicates microcirculatory thrombosis, that is the D-dimer level, we found that they were kind of a good indicators to initiate the anticoagulation. But later on in various studies, it has been shown that if we use therapeutic anticoagulation based on the D-dimer levels, we are likely to cause more bleedings and more harm than good. So that has not again stood the test of time. Some of the initial biomarkers which were used were the neutrophil to lymphocyte ratio NLR, or neutrophil, lymphocyte and platelet ratio, lymphocyte to platelet ratio. But these are very, very non-specific, and very many things can affect these ratios. So I believe of all the biomarkers, I would probably put a bet on the CRP here, to some extent ferritin. One question which is always asked is, what is the role of procalcitonin in patients with COVID-19? I would say that not directly related to COVID-19, but over a period of time, when you observe that this procalcitonin is levels are rising, once the patient has been on steroids and may not mount a febrile response, that may indicate a bacterial infection, but its role as a biomarker for COVID-19 is potentially doubtful.
Dr. Ashish, can you just tell the audience what is the cytokine?
Okay, if we can have the video. Yeah, welcome again. I think we have both Dr. Ashish and Dr. Hashimoto with us. So I'll request my co-panelists to please put on their videos and the audios on. So the next question, Dr. Ashish, to you is role of biomarkers in management of COVID-19.
Sir,
Ashish, please unmute yourself.
Yes, sir. Sir, I'm sorry, I just got distracted a little bit. You were asking about the
role of biomarkers in management of COVID-19.
Oh, sir, what all the eminent panelists have already discussed and addressed this issue. Only one thing, the practical biomarker to follow is probably CRP. Nothing else. You see, rest everything is kind of non-specific. The other thing which we initially kind of tried to follow was D-dimer, because we know that whenever we are using tocilizumab, sometimes D-dimer levels would go up after using tocilizumab. And in critically ill patients, we also observed that once they were admitted in ICU, sometimes their D-dimer levels would suddenly start going up. We tried using therapeutic anticoagulation, but we observed that these patients were having far more adverse effect bleeding. So that's why, and then later on it was proven that it's only the prophylactic anticoagulation which works. So I believe if I am given a chance within this time frame, when we have a lot of dengue, which can also cause low lymphocyte count, which can also cause lower neutrophil count and decreased platelets also. I'd probably follow only CRP and D-dimer. I don't think I'll follow any other biomarkers regarding the management of these patients.
Thank you. I think that's a fair answer. And the story that I showed in the first slide of the patient when he was very sick, it didn't make any sense because a lot of the biomarkers were still elevated when the patients had improved significantly. Dr. Hashimoto, most welcome to join this panel. So I think the tech team, please allow Dr. Hashimoto to share his slides if he asks so. Dr. Hashimoto, my question to you is, many a times we find patient is showing, GGO in the CT scan and bilateral infiltrates. All the clinical signs are suggestive of COVID-19 disease, but his RT-PCR is coming as negative. So can we rely on biomarkers for, making this diagnosis? Because we know the radiologists have been saying that if CT score is this much or these are the findings, you can be sure that this is, COVID. Whereas the regulatory agencies, both IDSA, FDA has been saying that no, RT-PCR is the most diagnostic. So in absence of RT-PCR, you can't say that this is COVID. Yeah, okay. Dr. Hashimoto.
So as you know, so there are so many people showing the very specific CT imaging. So it's very, in a way, very beautiful, spotty lung image. But sometimes we have no PCR positive data. But can you see this slide?
Yes, we can.
Yeah, so as this slide shows, virus isolation is the only way to detect the virus SARS-CoV-2 1 week before the symptom starts. And also, even the symptom start, so many patients shows only hypoxic state. They are like doing their routine life, they eat and speak, and then suddenly 3-4 days after that, their condition deteriorate very rapidly. So I agree all panelists discussed here, and I have very little to add, that it's very difficult to handle these patients, especially for critically ill. And proper control of coagulation system is the key, one key to protect these patients from dying. And also the secondary infection is the key to stop their deterioration. So in that way, D-dimer and the CRP is the only way to detect the deterioration. Also, in Japan, we use heparin, and proper control of coagulation by heparin is monitored by APTT. It's not a biomarker, it's a very good way to know this. And also diagnosis test. So PCR would be the best method to detect SARS-CoV-2. And knowing whether cycle threshold CD value are high or low can be highly informative. But there are several issues we should bear in mind. So we have many kinds of machines that shows the different CD value. But I think so CD values under 25 would be the marker to show the prognosis of the patient. And also, so we investigated prognostic tests like Apache 2 or Apache 3, whether these prediction models can accurately predict the mortality, but no, there's no way. So they can't predict the prognosis. And also, prognosis test, there's no realistic prognosis test for COVID-19 so far. Prolonged CD value, as I said before, 25 or below in PCR might be used. for the prognostic marker. The lower, the worse. And ferritin, SPD, D-dimer, LDH, LP, and CD value might be the candidate to detect prognosis of COVID-19, but I'm not sure, so as all panelists said before. Thank you.
Thank you, Dr. Hashimoto. So my question to the entire panel, those who are here, is, we have seen that these biomarkers, acute phase reactants, they are increased or raised in COVID-19, especially the severe ICU patients. And this could be the trend also, and it has also been reported to be high in sepsis patients, but we are routinely not monitoring them in all sepsis patients. So should we be doing the same for sepsis patients also, at least to look at the severity of the disease? Dr. Ashish, you are smiling.
Yeah, we're learning so much. COVID has really taught us so many things. A part of adult learning is that you have to unlearn, relearn, and, go about improving your knowledge. When we started managing COVID-19 patients, we were doing the whole lot of tests every day. And we realized that we're wasting our time and money. You're wasting your precious resources when you are repeating these tests every day. They don't give you a battery of tests every day. Whenever the patient is going down, whenever the patient is deteriorating, then you probably send the investigation, might help. This virus is producing a response which would be like a severe sepsis or septic shock in a patient with bacterial infection. Yes, there could be a role of doing a serial kind of a testing for inflammatory parameters like CRP. But I would believe that at the end of the day, it is not the numbers that we are treating. If I find a CRP value high and the patient stable or patient kind of improving, am I going to jump and change a medication? No, I might not do that. So that's once the patient is going down, not improving, or remaining static at one particular point, then you have some value of doing these biomarkers. Once the patient is improving, I don't think daily biomarkers in any condition, may it be COVID or may it be sepsis, is likely to give you any definitive treatment guidelines.
Thank you. Dr. Hashimoto, we have seen, over the last 1.5 years, this story evolving about biomarkers and their implications in COVID, different papers, different experience, mostly observational studies, what people observe in China or elsewhere have been reported. We also reported our own data. But, now that COVID is on a decline, fortunately for us, at least in India, a lot of people are vaccinated now. So where do you see retrospectively, I mean, what was the actual role of biomarkers? Were we overdoing it, or, we didn't know, like Ashish said, we are learning, unlearning and relearning. So was it part of that learning process, or where do you see, if you retrospectively analyze your COVID experience?
Wow, it's a very difficult question to answer, but we are now processing our data retrospectively and try to understand how this process is going. So we learned more and more, but I'm not sure I can show you the answer right now. Okay, as Dr. Ashish said, so we monitor these biomarkers from time to time, but so I myself can't find any relationship.
Okay. Thank you.
Higher the worse.
Yes.
That's the only answer.
Yes. So I think we have come to the end of the discussion, and we are about to finish our time. So just to summarize what the esteemed members have told the audience is that, you know, the biomarkers are found to be high. And if the initially in acutely sick patients or severe COVID patients, the biomarkers are extremely high, they indicate a severity associated with it and possibly will have an outcome impact. Like Dr. Shrikant said, that IL-6 would, if initially is high and other values are high, they would implicate, you know, a severe outcome. Similarly, D-dimer values, if they are high, would suggest the thrombogenic processes that are going on. But to correlate in a long-term way, you know, the values of these biomarkers to the clinical condition of the patient would possibly be far-fetched. Like Dr. Ashish said, CRP possibly is the one that is the best marker. But again, in the long run, these are, most of them are acute phase reactants. So say 7 days, 10 days, 20 days into the illness, what would be their role and how do we interpret? Possibly the less often we do it, the less confused we will be. And I think they would be raised anyway in any septic pathology, any inflammatory pathology. So with these words, I would like to express my sincere thanks and gratitude to the speakers for taking their time out, and also congratulate Dr. Rungta for organizing this wonderful meeting on COVID-19. Thank you very much. Back to the organizers. Thank you.
Thank you.
Thank you.
Thank you so much, sir. It was a very wonderful and an informative session. Now, moving towards the thematic session 1. On chairing this session, I would like to welcome Dr. Kundan Mittal, Professor and Head Unit 3, Department of Pediatrics, PGI Rohtak, Haryana. Dr. Himanshu Bansal, Radiologist.
Dr. Nida, the session is going to start at 1.
Okay.
Yeah, you can ask everyone to join back at 1 o'clock.
Okay, then we'll start it at 1.
Dr. Nida?
Yes, Shilpi?
Yeah, so the next session is going to start at 1 o'clock. Okay, I have sent out a text to all the chairpersons and the faculty members already. If you want to get in touch with anyone, you may do that. And you have the
Shilpi,
call.
I cannot hear you. 1 second.
Sorry? Are you saying something?
No. Shilpi, you continue what you were saying.
You are not audible to me.
Is it okay now?
Yeah, it is better now. Yes, tell me. आप क्या कह रहे थे?
मैं क्या 1 o'clock पे यही ना डॉक्टर कुंदन मित्तल, हिमांशु बंसल.
हाँ जी. Right.
And I have to introduce the speakers also, or they will introduce the speakers?
No. You have to kickstart the session by introducing the session, thematic session 1, and then you would be introducing the chairpersons, and then chairpersons would be introducing each speaker. So maybe one chairperson can introduce one speaker. That way they can decide amongst themselves.
Okay.
ठीक है, सीरीज है ना आपके पास सारे. अच्छा, just to let you know, 1 minute, I'll tell you something. डॉक्टर शैलेंद्र छाक को मत करना. डॉक्टर शैलेंद्र छाक will not be joining in, although उनका CV में मैंने सिर्फ नाम रखा हुआ है, since Deepti ma'am had told me not to remove the name, but he will not be joining in.
Okay.
ठीक है?
Okay.
हाँ, and also who is going to anchor this thematic session too?
Dr. Ankita.
डॉक्टर अमृता.
अंकिता.
अच्छा, डॉक्टर अंकिता को ये बता देना कि डॉक्टर अपूर्वा मित्तल हैं चेयरपर्सन, जो प्रोग्राम में उनका नाम दिया हुआ है, बट ही विल नॉट बी ज्वाइनिंग इन. ओके, तो सीवी में उनका नाम नहीं है, so if you want to cut it down on your program you may do that.
क्या नाम बताया? डॉक्टर
अपूर्वा मित्तल.
ठीक है, उनका नाम हटाना है.
हाँ, मतलब प्रोग्राम में डाला हुआ है, बट जो मैंने सीवी शेयर करे हैं उसमें उनका नाम नहीं है.
उसमें नहीं, हम सीवी वाला ही ले रहे हैं.
हाँ, मैं इसीलिए बता रही हूँ कि कंफ्यूजन ना हो, प्रोग्राम में अलग हो और उसमें अलग हो, इसलिए बोल रही हूँ. ठीक है ना? ओके,
बाय
बाय.
वॉल्यूम फिर से कम हो गई है.
Hello, Dr. Nida. Can we start? Hello. Hello, Dr. Nida. Hello. Hello, Dr. Nida. Are you here? Hello, Dr. Nida. Hello. Dr. Nida, I'm audible.
ऋषभ मैं एक बारी ना कॉल करती हूँ उनको.
Okay, ma'am. Okay.
Hello.
Hello. Yes, Dr. Nida, can we start?
Yes, sir.
Just start your video.
So just before we start, Dr. Kundan Mittal will be joining in a while, and कुछ उनका issue
Shilpi,
चल
am
रहा
I
है.
audible to you?
Yes,
Yes,
now
you are
you
audible.
are, but we've been calling your name. Please be little attentive here, yaar.
Okay. Should I
Yeah,
start
Dr.
now?
Rimanshu is here. Maybe we can start off with Dr. Rimanshu, and in the meanwhile, I'm following up with other doctors also.
Now, starting with the thematic session. Shilpi, should I start now?
Yes, you may please.
Okay. Starting with the thematic session, I would like to introduce our chairperson, Dr. Kundal Mittal, Professor and Head Unit 3, Department of Pediatrics, PGI Rohtak, Haryana. Dr. Rimanshu Bansal, Radiologist, Usha Mission Hospital, Batinda, Punjab. Dr. Sharmila Panjwani, Obs and Gynecologist, Pushpanjali Hospital, Research Center, Agra. Now, I would like to request Dr. Kundal Mittal to introduce the first speaker of the session. Kundan sir, are you there? I would like to request Kundan sir to introduce the first speaker of the session.
Your voice is not coming, sir. Hello. Dr. Kundan, your voice is not coming.
Can Dr. Rimanshu introduce Dr. Shyam Sundar, please?
Yeah.
And also Dr. Sharmila Panjwani will not be joining in.
Should I start?
Yes, ma'am.
Okay, am I audible? Clear?
Yes, ma'am, you are audible.
A very good afternoon and welcome everybody to this World Conference on COVID and Critical Care. So we have the first lecture by Dr. T. Shyam Sundar, who's a medical director with Bombay Hospital, Hyderabad. Dr. Shyam Sundar, please.
Good afternoon. For the next 10 minutes, we will be discussing about the incidence of mucormycosis, which was seen very rampantly during the COVID and the post-COVID pandemic time in the last 1.5 years. So the incidence of mucormycosis was reported very high during the pandemic, and increasing reports of rhino-orbital mucormycosis in India was seen in a very rampant way. The highest number of cases in the world have been reported from India. Probably diabetes was the cause. There was an union of unholy trinity of association of diabetes, rampant use of corticosteroids in the background of COVID-19 infection. Along with this, both aspergillosis and candida was also been reported, but more cases of mucormycosis was seen in patients infected with COVID. So the factors which were responsible for this high incidence of the spores germinating in patients infected with COVID were the patient's background of hypoxia and persistent hypoglycemia, be it diabetes or a new onset of hyperglycemia during the infection or steroid-induced hyperglycemia. Associated with this is the acidic medium, the pH being low, acidic state either because of diabetic ketoacidosis, or most of the patients have received vitamin C as a supplement which added to the acidic medium of the blood. The other factors were increased level of ferritin and decreased phagocytic activity of the WBCs during the immunosuppression, and steroid-induced comorbid conditions. The other factors were prolonged hospitalization with or without mechanical ventilation, and more so during the COVID acute phase, there was cytokine storm, lymphopenia, and endothelial damage. All these factors have contributed to increased germination of these fungus in the body. So mucormycosis is a very angio-invasive disease caused by the fungi of genus Rhizopus. So all of us know the mode of contamination is inhalation of the spores. The fatality rate had been very high as 90%, because of rapid dissemination. And it is an extraordinary phenomenon seen in this particular fungal infection. And even a delay of 12 hours proved to be fatal. Unfortunately, we have seen about 50% of the cases were reported in the postmortem cases. So associated with this are the several other immunocompromised conditions which predispose to mucor are, apart from diabetes or diabetic ketoacidosis, the hematological malignancies, neutropenia, and organ transplant patients, patients on immunosuppression, patients with iron overload, patients with burns, HIV and AIDS, and polytrauma who had COVID infections, had shown higher incidence of mucor in during this period. So mucor usually involves in the nose, in the sinuses, in the orbit, in the central nervous system, pulmonary, GI tract, and jaw bones, joints, and mediastin. ROCM is a commonest form of manifestation. So rhinonasal, rhino-orbital, cellular are usually seen in patients who had COVID infections with a comorbid condition of diabetes. So the criteria for the clinical diagnosis is the gold standard is the clinical manifestations and early recognition of this, like if we notice the black necrotic turbinates, which is usually mistaken as dried crusted blood, blood-tinged nasal discharge and the facial pain both on the same side, and soft periorbital or perinasal swelling, discoloration, and indulation also gave a suspicion of mucor. And most commonly we have seen is ptosis of the eyelid, proptosis of the eyeball, and complete ophthalmoplegia with multiple cranial involvement, which was seen especially in late diagnosis. So the treatment which was given during this time is being a multi specialty approach, like a team approach between the intensivists, the internists, the endocrinologists, the neurosurgeons, the dental surgeons, and the ENT surgeons together, have done a great teamwork in saving these patients. And the most important thing being control of diabetes and ketoacidosis. And it has been proved throughout that a proper euglycemia has reduced in incidence of infection. Likewise, reduced use of steroids and one suspected discontinuation of the immunomodulators also proved to lessen the incidence of mucormycosis. And those cases which were detected at a later stage needed surgical debridement with the help of the team of neurosurgeons, dental surgeons, and facial-maxillary surgeons. Together, along with ENT surgeons, have done many cases with extensive surgical excision of the necrotic material, and during which, after the excision of this necrotic material, there was an improved penetration of the antifungals which were given. The most common antifungal which was given was amphotericin, and before that, because amphotericin has to be given for more than a week, so there was a need for a peripherally inserted central catheter, and a proper adequate hydration was mandatory before giving this antifungal. So liposomal amphotericin B, which was given at a dose of 5 milligram per kg per day in 200 cc of 5% dextrose over 2 to 3 hours, was the main drug which was used during the suspicion of diagnosis of mucor in patients with COVID. And when liposomal was not available, plain amphotericin B was given at a dose of 1 milligram per kg per day in 5% dextrose over 2 to 3 hours. And during this administration of amphotericin, monitoring of the renal function and potassium levels at a regular time was essential to treat the incidence of hypokalemia and hypomagnesemia, which is usually seen during the treatment and the post-treatment phase. So those patients who were allergic to amphotericin, the other two antifungal drugs like posaconazole and ivasaconazole were given. Intravenous posaconazole 300 milligram twice a day on day 1, and 300 milligram once a day, which was given for a week, and the serum levels were done on day 7. And which posaconazole is available as oral syrup form, whereas isaconazole was given at 200 milligram thrice a day for 2 days. So while patients were having suspected of mucor in patients with COVID, with the premorbid or comorbid conditions which I have enumerated in earlier slide. So associated with surgery, associated with medical treatment for this patient for over 2 weeks, the monitoring, there was a close monitoring of these patients, both clinically, microbiologically, and radiologically, which was followed up after 3 to 6 weeks of amphotericin, which was later on followed by posaconazole and 3 to 6 months of period, which gave a better recovery of these patients who were infected by this fungi during the episode of the COVID infection in the recent pandemic. Thank you very much.
Thank you, sir. It was a very wonderful presentation. Now I would like to request Dr. Kundan Mittal, sir, to introduce our second speaker of the session.
I welcome Dr. Gyanendra Agarwal, who will be speaking on radiology for intensivists. Over to Dr. Gyanendra Agarwal.
Good afternoon, everyone. I must congratulate and thank the organizers for bringing out this conference in such a nice way. My job is to talk on radiology for intensivists. Since this is a big topic, I'll restrict myself to acute respiratory failure, which means radiology in acute respiratory failure. So if we see any ICU, the most common causes of acute respiratory failure are pneumothorax, pneumonia, pulmonary edema, pulmonary embolism, and acute exacerbation of COPD. In fact, most of the studies suggest that more than 95% of patients who present with acute respiratory failure in an ICU will have one of these 5 differential diagnoses. So let us take them one by one. Pneumothorax. Pneumothorax is very easy to diagnose in a patient who has got erect chest X-ray. Like as you see on the left-hand side of the screen, the lung collapses and the extrapleural air is seen in the form of increased translucency, and this is called as lung edge. But then pneumothorax in supine position looks differently because air traverses to the most non-dependent part of the lung, which is anterior or anteromedially or anterolaterally. Like in this figure, if you see, the air traverses to the most non-dependent part, which is either anteromedially or anterolaterally. So a chest X-ray which has got 2 dimensions or a 2-dimensional film, this may not appear like the classical lung edge, as it is seen in a patient who has got erect where the air traverses to the most non-dependent part, which is usually the apex. So how does it look like? Pneumothorax may look as if like a deep or a tongue-like sulcus, the lateral sulcus. So if we see the corresponding CT scan, it will look like this on the right-hand side of the screen, and this is called as deep sulcus sign. The extra air in the right hemithorax may displace the dome of diaphragm, which is represented by the white arrow, or it may also displace the anterior costophrenic angle. So it may look as if there are 2 diaphragms on the right side. So this is called as double diaphragm sign. So this is another sign of pneumothorax in a supine position. Similarly, the pleural effusion is not seen as a convex opacity as it is seen in the erect position. So in supine position, the pleural fluid also tends to gravitate and forms a uniform layer, and it is seen as an increased radio opacity in the hemithorax, like in this chest X-ray, where the patient has got right-sided pneumothorax with underlying consolidation and the pleural fluid. So other signs of pneumothorax in supine position are relative transradiancy in hypochondrial region. It may appear as increased sharpness of mediastinal margin and diaphragm, increased sharpness of cardiac borders, particularly at the apex, lobulated, rounded, and often mass-like appearance of pericardial fat pads, depression of ipsilateral diaphragm, or there may be visualization of inferior edge of the collapsed lung. But then always the lung edge, which is seen, may not be a true pneumothorax, and it can be actually an artifact, especially if the bronchovascular markings are seen outside the lung edge. So this is actually a skin fold on the right side of the chest. Similarly, the extra translucency on the left side may not always be extrapleural air. It is actually the stomach bubble, and which has displaced the diaphragm upwards in a patient who had polytrauma because of accident. So this is stomach lying on the left side of the chest. And in one of our patients, he had actually the large bowel obstruction, which intersposed in itself between the right hemidiaphragm and the liver, which may appear as a pneumothorax. But before putting in a chest tube, if there is any such doubt, one must always do a good quality CT scan or maybe lung ultrasound. So lung ultrasound has come up in big way, and they're really, really helpful in day-to-day clinical practice, especially to diagnose the cause of acute respiratory failure. So like in this, normally the lung ultrasound, we see the pleural line wherein the sliding sign is seen, the visceral and the parietal pleura slides on each other, and multiple artifacts which are equidistant from this pleural line are seen in the form of A line. So these are the normal lines which are seen on a lung ultrasound. And if we turn on the M mode, then these lines may be seen as the sandy pattern herein, as if you see on the right side. This is a normal lung which is seen as the sandy pattern, and the pleural and the pleura are seen like the like the sea waves. So this is called as seashore sign. What happens if the patient has got pneumothorax? The lung sliding is absent, and if we turn on the M mode, the sandy pattern disappears because it is all the plural line which is seen all over on the M mode, and this is called as the stratosphere sign. If we see a junction of stratosphere sign and the seashore sign, this is very important, and this is called as lung point, and there is hardly any differential diagnosis of lung point, and it is almost confirmatory of pneumothorax in a patient in ICU. So basically lung point is seen at this junction wherein the extrapleural air is there, and on the junction where the lung is just approximating the chest wall. So this is very important, and this is mainly seen in patients who have got mild to moderate pneumothorax. Obviously, if the patient is having large pneumothorax, then we don't expect lung point to appear. So ultrasound, as I said, is not only useful in diagnosing pneumothorax, but it is very useful in diagnosing all causes of acute respiratory failure in ICU. It has got very good sensitivity, and see, the specificity is even more higher. So ultrasound has become the modality of choice, and if we follow certain scientific protocols, it becomes very easy to shortlist the differential diagnosis of acute respiratory failure in an ICU patients. It is very easy to do, and of course it can be repeated, and the information can always be saved. So the dictum is, when your patient is blue, when your patient is cyanosed, perform blue protocol. And who should be doing it? No, it's not by the radiologist, but it is the domain of intensivists, and every intensivist must know to do lung ultrasound. The second most important cause of respiratory failure in ICU is pneumonia. Of course, chest X-ray is the cornerstone for diagnosis. There are 5 signs of pneumonia on chest X-ray. First and foremost is the increased opacity, which is bounded by a well-defined interface. Like in this patient, it is bounded by the minor fissure. The second important sign is the salute sign. So whenever any radio opacity salutes with the normal border on chest X-ray, it is called as salute sign. Like on the left hand side, if you see, this opacity is saluting with the right cardiac border, which means the opacity is in the right middle lobe. Similarly, here in the opacity is saluting with the right side of the diaphragm, which means the opacity or the abnormality is in the right lower lobe. So if we understand the anatomy of thorax on a chest radiograph, it becomes very easy to diagnose which part of the lung is affected, and one can do the sampling, directed sampling from that particular lobe or segment or subsegment. Asymmetric increase in lung opacification, especially with the presence of air bronchogram, is almost certain of a consolidation on a chest X-ray. Now, this is very important for the intensivist, especially on a supine film. So normally, if you see, medial 1/3 of the diaphragm on the left side is not seen, whereas the lateral 2/3 is usually seen. If the diaphragm is not seen on the left side, then definitely there is some abnormality in the left lower lobe. If you see closely this chest X-ray, there's something called as double cardiac border, which is seen in this patient. And herein, actually the left lower lobe of the lung is collapsed. Similarly, on this chest X-ray, again, there is problem in the left lower lobe. So this is very important sign on a supine film. Of course, multifocal consolidation is the 5th and very important sign, which we do come across in our ICU patients, which is a sign of pneumonia. But then we must remember, not every opacity is pneumonia. It can be collapse, it can be pulmonary hemorrhage, it can be pulmonary infarct, or even loculated fluid or pus. Serial chest radiographs are very commonly done in any ICU patients. So most important message is that serial chest X-rays are done to see the worsening of the patient and almost never to see the improvement. But then if the patient is clinically improving and there is associated clinical and the radiological response, then the differential diagnoses are very few, and it can be either cardiogenic pulmonary edema or the diffuse alveolar hemorrhage. It cannot be ARDS, it cannot be pneumonia, because the radiological opacity may not improve very fast in these patients, and lack of radiological resolution by 6 weeks qualifies for non-resolving pneumonia. CT scans are rarely done, but then it is useful for diagnosing non-resolving pneumonia or assessing the complications of community-acquired pneumonia. Ultrasound is coming up in big way, and it is also really very helpful in diagnosing pneumonia. So the third most important thing is pulmonary edema. We know the common signs of pulmonary edema on chest X-ray. To differentiate which pulmonary edema, whether it is cardiogenic pulmonary edema or ARDS, we have got certain subtle signs. The most important one is if the chest X-ray changes coincide with the onset of symptoms, it is almost diagnostic of the cardiogenic pulmonary edema, which actually also resolves on the serial films. Whereas in a patient who has got ARDS, this clinical and radiological may not be coinciding with each other, and these findings may be actually disproportionate, and they usually stuck and they are with the generalized opacification. So in ARDS patients, the radiological opacities may persist for long, and the serial chest X-rays are done to see the worsening rather than to see the quick improvement. B lines, also called as lung rockets, are actually the comet tail kind of artifacts which represent the wet lungs. So this qualifies for pulmonary edema. Again, multiple kinds of ultrasound profiles, and if we do them in scientific way, it is very helpful to diagnose the cause of pulmonary edema. CT scans are rarely done for diagnosing pulmonary edema, but in a subset of patients, to know the cause of ARDS, which are called as ARDS mimics, CT scan are really helpful. Like I'll show you some of our patients. So on this chest X-ray, it's difficult to differentiate what is the cause of ARDS in this patient, but CT scan really helped us in diagnosing diffuse alveolar hemorrhage because of ANCA-associated vasculitis in this particular patient. Similarly, another similar kind of chest X-ray, when we did CT scan and other clinical findings, this was suggestive of acute interstitial pneumonia. Another patient who presented with ARDS, CT scan showed multiple confluent nodules, and this patient was diagnosed to have tubercular ARDS. So pulmonary embolism, a very understated diagnosis, and it must be suspected in any patient who has got acute respiratory failure, acute onset hypoxemia with apparently normal chest X-ray. This is very important. CT pulmonary angiography is the gold standard to diagnose pulmonary embolism. But if you do a non-contrast CT and if you find something hyperdense in the pulmonary artery, again, it has got no differential diagnosis. And this is also almost certain of pulmonary embolism. So this is called as hyperdense sign on CT. Lastly, acute exacerbation of COPD. Again, apparently normal chest X-ray. Yes, we may find hyperinflated lungs, which is represented by more than 7 anterior ends of the ribs. But I feel the most important sign of emphysema on chest X-ray is the undulated contour of diaphragm, which represents actually the emphysematous bullae on both sides. So this is very important sign of emphysema on chest X-ray. Of course, if we do CT, then we may be able to differentiate which type of emphysema, whether it is centrilobular, paraseptal, or panacinar, it may be useful to diagnose. So to conclude, knowing basic radiology is very important to know the cause of respiratory failure. Chest radiographs look differently in supine position. We must keep in mind, serial chest X-rays are done mainly to see the worsening, and if they are showing improvement, then it is not ARDS, then it is either pulmonary edema, cardiogenic pulmonary edema, or diffuse alveolar hemorrhage. Ultrasound is a must-know thing by all intensivists, and it is the need of hour. A good quality HRCT scan may reveal ARDS mimics, and if we are not able to diagnose the cause of ARDS, a HRCT scan must always be done. And CTPA, the threshold of doing CTPA should be very less whenever we see a patient who has got unexplained hypoxemia. Thank you all for patient hearing, and I am ready to take up if there are any questions. Thank you all. Thank you once again.
Thank you so much, sir. So you have explained each and everything in a very simplified manner. Now I request Dr. Himanshu Bansal to introduce the third speaker of the session.
A very good afternoon. It gives me great pleasure to introduce Dr. Srinivasan, who is a consultant, critical care medicine, Manipal Hospital, New Delhi. Over to you, Dr. Srikant, sir.
I'm going to speak about the role of non-invasive ventilation in COVID-19. We know that non-invasive ventilation has been clearly validated, at least in context of cardiogenic pulmonary edema and COPD exacerbation, where it's a level 1 recommendation. However, the role in acute respiratory failure, hypoxemic acute respiratory failure, and ARDS still remains very controversial. There's a high incidence of failure of non-invasive ventilation, especially when the PF ratios go below 150, and subsequent need for intubation and ventilation and poor outcome of patients. But despite the evidence not supporting the use of widespread use of non-invasive ventilation in ARDS, we have used non-invasive ventilation to a lot of patients in the COVID-19 pandemic. We all have used it. This invent came about just because our health system was frankly exhausted, overwhelmed with the large influx of patients with acute respiratory failure and the lack of enough amount of mechanical ventilatory devices or expertise for intubation, for which a lot of patients required non-invasive ventilation. A lot of patients did well on non-invasive ventilation as well. Non-invasive ventilatory support, whenever possible or feasible, has some advantages. It reduces the dose of sedatives. It causes lesser amount of delirium, facilitates mobilization, prevents secondary infection, and ICU-acquired weakness. And there are numerous papers which have come about in the last couple of years, which have shown that non-invasive ventilation in COVID-19 ARDS could be a viable strategy. Now, this is one such paper which came out in 2020, which said that non-invasive ventilation can avoid intubation in almost half the patients, and they felt that the data would be reassuring, considering the use of non-invasive ventilation because in patients of COVID-19. A much more larger database was seen in this sub-analysis from the HOPE registry, in which 1933 patients were taken, of which 390 patients, that is 20% of the patients, required non-invasive ventilation. There also they found almost half the patients survived without the need for intubation. And they felt that this could be a viable strategy, especially in overcrowded and resource-limited settings. But they did add a very important point that prompt identification of failure is mandatory to avoid increased mortality. A more recent paper by the American Journal of Emergency Medicine compared primary use of non-invasive ventilation versus endotracheal intubation for treatment of COVID-19 patients. And what they found was utilization of non-invasive as an initial intervention, as the first intervention during COVID-19, is associated with a significant survival benefit. And they also found that patients who were intubated after NIV failure, there the mortality rate was not worse than those who underwent intubation as the first intervention. So effectively what they're trying to suggest that early intubation of patients who could be otherwise managed on non-invasive is not very helpful in COVID-19 ARDS. So they did suggest that most of the patients should be given a cautious trial of non-invasive ventilation, failing which only they should go on to invasive ventilation. Early intubation by itself has its own risks. First and foremost, we will not be able to give patients benefit of improving on CPAP and non-invasive ventilation who might have otherwise benefited just on these less invasive measures. And if you intubate the patient early, then you're already using up one ventilator and using up the expertise for intubation, and patients who actually need it may be denied it, and this is more so in resource limited settings. And in case all the resources are already exhausted, then resorting for non-invasive ventilation may pose a lot of anxiety among the staff who might feel that they are giving suboptimal therapy to the patients. Now, this comes down to the most important question, that is it that non-invasive ventilation helps or harms patients with COVID-19 ARDS? So we know that historical failure rate of non-invasive ventilation in ARDS is around 50%. So that is one which is there on the background. Additionally, non-invasive ventilation, especially in the settings of COVID-19, may cause further harm because of two reasons. One, risk to the healthcare giver. Non-invasive ventilation can lead to release of aerosols, and aerosols contain the live viruses, which can be very deleterious or contagious for the healthcare person who is involved in the care of the patient. And secondly, non-invasive ventilation may actually harm the patient. Why? Because since we know that quite a few patients have a very good compliance, which is preserved with COVID-19 ARDS, they may generate very large tidal volumes of 9 to 10 ml per kg and more. And that leads to what's called patient self-inflicted lung injury, or PSILI. And this uncontrolled tidal volumes, if it's not very clearly monitored with non-invasive ventilation, can further worsen the patient condition and outcomes. Secondly, non-invasive ventilation may transiently improve the oxygenation but not change the overall outcomes. So it may end up delaying intubation in certain patients who actually would have benefit from intubation early, and hence that leads to overall poor outcome of the patients. Now coming to, let's talk about these two individual issues one at a time. Does it increase the risk of exposure to the staff? Well, we know that SARS-CoV-2 virus can remain viable in aerosols for up to 3 hours. So any procedure which generates aerosol, may it be intubation, extubation, bronchoscopy, nebulization, use of non-invasive ventilation, spontaneous breathing effectively, can lead to release of aerosols. If you have an improperly fitting mask, they can cause leak around the mask, and that can lead to further generation of aerosols and exposure to the staff. So let's take you back to a study which was there in 2017, which studied the dispersion of aerosols simulated by smoke while using individual oxygen delivery devices. So they found that when we use a nasal cannula with 5 liter per minute flow of oxygen, the dispersion of aerosols is almost 100 centimeters. On the other hand, when they use non-invasive ventilation, a tight-fitting mask with a pressure of 18 centimeters of water, the dispersion distance was 92 centimeters. So effectively, non-invasive ventilation does reduce, if you have a tight-fitting good mask, you can minimize the widespread dispersion of exhaled air and hence have a lower risk of airborne transmission from the patients. This is specifically true when we use a helmet. So that would be preferentially be used, especially in the SARS-CoV-2 pandemic, because it's a highly contagious virus and you need to not want to release too many aerosols. Secondly, if the patient, the healthcare giver should be always attired in the appropriate personal protective equipment. Endotracheal intubation is one of the modalities which has a maximum risk of aerosolization because of the proximity of the healthcare giver to the patient. So the notion that early intubation avoids the use of CPAP or NIV, hence decreases the risk of viral transmission, especially where everybody is using PP, is debatable. And WHO guidelines do advocate the use of CPAP or non-invasive, provided the appropriate PP is being worn. Now coming to the second question, does non-invasive ventilation harm the patient? We know that spontaneous breathing with uncontrolled volumes can lead to very large pressure swings, especially when the compliance is still preserved. And this transpulmonary pressure swings, as you can see, when you have an active breathing, the transpulmonary pressure swings is very high. And when you have some amount of support, like as you use CPAP or non-invasive, there is still good amount of swings, but it's somewhat mitigated. So this extreme large swings can lead to what's called patient self-induced lung injury. And as I said, the second point was delayed intubation by falsely feeling that the patient is getting better. So let's talk about patient self-inflicted lung injury to some extent. This was a very good article which came out in BJA in 2021, a narrative review, which said that no clinical study has demonstrated that a ventilatory strategy to limit the risk of PCL can improve patient outcomes, particularly in patients with COVID-19. So it may be unavoidable to some extent, especially in patients with COVID-19, but 3 approaches have been suggested to minimize the effect of PCL. 1, limitation and monitoring of tidal volumes, application of PEEP, and reduction to some extent of spontaneous effort by appropriate sedation and metabolic control. The issue being that non-invasive ventilation, since temporarily will increase oxygenation, but unfortunately the course of disease is long, it goes on for weeks. So this makes recognition of patients who are at high risk of disease progression and hence optimal timing of intubation quite challenging. So we have to resort to the criteria for failure of non-invasive ventilation and consequent need for intubation. This is the criteria which are well established as per the official ERS, ATS clinical practice guidelines. And obviously failure of non-invasive is defined as persistent or worsening acute respiratory failure, saturation less than 88% with a respiratory rate of more than 36 despite optimal settings of non-invasive ventilation, or development of conditions which will require endotracheal intubation like need to protect the airway. Patient becomes unconscious or has a convulsive disorder, to manage abundant amount of secretions, or patients develops hemodynamic instability. Besides this, there are objective criteria or objective scores which also have been devised, which we can use to see for non-invasive ventilatory failure. So one such score is the HACOR score, which involves pH, GCS, PF ratio, and ventilatory frequency. Other one is the COVID-19 score. So a HACOR score of more than 5 will predict the failure of non-invasive with accuracy of sensitivity of 83%, specificity of 92%. So these are relatively very useful scores which can be used, although they haven't been validated for COVID-19 per se. So this could be the non-invasive ventilation protocol, especially in patients with a PF ratio of less than 200, Try to limit tidal volumes with around to 5 to 6 ml per kg. Try not to go beyond 9 to 10. At least do not cross 9 ml per kg persistently. And check after every couple of hours, especially where the parameters regarding the respiratory rate or the CO2 levels or the pH levels are maintained. At any stage you feel that the non-invasive ventilation is failing, we should go ahead and intubate the patient. So what happens as compared to other patients who used to be intubated once the non-invasive ventilation fails? The outcomes are very bad. We know it. Historically, they were bad. But what was the outcomes of COVID-19 patients who were intubated after failure of non-invasive ventilation? This was a multi-center observational study, the Vento ICU network group in Italy. 704 patients, 280 patients were enrolled who failed non-invasive ventilation, went on to intubation. And what they found that the overall ICU mortality after non-invasive ventilation failure was 43%. The length of NIV after ICU admission did not affect the patient outcome. The only thing which affected the patient outcome was use of NIV prior to admission to ICU. That's one, that is use of NIV in wards and HDUs and advanced age. So this is in a nutshell regarding the safety issues, optimization, indications and modes regarding NIV use in COVID-19. The level of evidence, as you can see, is mostly weak or ungraded. So it's definitely something which is not very, very strongly evidence-based or evidence-backed, but it is something which can be still done. And helmet is the one which is preferred as compared to the full face mask with regards to safety issue. So effectively, there are 5 steps. Try to isolate patients, keep them in a COVID ward, choose a helmet, choose a double limb with a filter in the expiratory limb, and reevaluate the patient again and again. So to conclude, it showed that non-invasive ventilation is effective in almost half the patients. It helps to reduce the pressure on the ICU in a dramatic scenario, and widespread use can reduce the amount of depletion of ICU resources and the high demand for ICU beds. But very importantly, prompt patient identification of failure and proper patient selection is mandatory. NIV just can't be applied and forgotten. You have to follow up the patient, keep a regular close monitoring of the patient. So this is essential for success of NIV, especially in this subset where we are totally overwhelmed, and a lot of patients may actually benefit from NIV, but those who have to fail will fail even on NIV. So those people should be identified promptly. Thank you.
Thank you, sir. Sir, it was really a comprehensive talk. Now I'll request Dr. Kundal Mittal to introduce the fourth speaker of the session.
Anyone have any question? Anybody? Dr. Shimant Kumar Jha. Dr. Shimant Kumar Jha will be speaking on PCR in suspected COVID critical listed patients. Over to Dr. Shimant. Over to Dr. Shimant Jha.
I'm thankful to the W4C committee, especially Rungta sir and Dr. Ranveer, who has given me this opportunity to talk about false negative RT-PCR in suspected critically COVID patients, the way forward. Now, why RT-PCR tests are not so accurate? What is the reason? Just because high number of false negatives result could be the variability in viral settings. What viral setting? Which is the rate the virus leaves your body after when it can no longer reproduce. This has been taken from quote from the researchers of Johns Hopkins. And the next thing is faulty sample collection technique may also be to blame, which can happen if a clinician does not swab deep enough to collect the necessary samples. Means if the swab is going inside with that one, so it has go into the nose in a rotating fashion deep inside the nasopharynx, and the other sample should be taken from the mouth. Wide, you have to ask the patient to open the mouth widely, and then you have to collect sample. Just when the patient starts gagging, then you have to take it out. So sample collection is as important for getting the test positive. What CDC does? CDC is Center for Disease Control and Prevention, USA, they are telling some test kits possess faulty reagents, the chemicals, that is the chemicals used in tests to help detect SARS-CoV-2. The Nancy Messner, MD, Director of the National Center for Immunization and Respiratory Diseases at the Center for CDC, explained that tests may not always work as well in other labs because CDC, they have got a high-end lab, leading to the inaccurate or inconclusive results if we are comparing other labs with the CDC lab. And to circumvent this, the CDC is taking extra measure to ensure high-quality reagent manufacturing. Again, sample collection, and at the same time, high-quality reagent manufacturing is also important because faulty reagents can lead to false negative tests. Early research indicates that common tests for COVID-19 may produce false negative up to 30% of time, as per as the researchers at Johns Hopkins. What they are telling, 70% cases you can have the positive results, but in 30% cases it can be false negative. Experts say that inaccuracies are probably, we have already talked about the collection of samples, not the actual laboratory testing, but maybe the environment and the chemicals being used could lead to the false negative results. The issue with the test for SARS-CoV-2 virus is that there has been time to test them rigorously because just because of COVID, everything was hurriedly, even the vaccine came hurriedly, and everything, kits and everything came so hurriedly. So it should have been tested rigorously before deploying them in the field. They say that people who have COVID-19 symptoms should assume they have the illness even if the test is negative, just because to avoid further spreading of virus. The RT-PCR test is basically a molecular-based test that detects traces of pathogens, materials, in this case, the genetic material of SARS-CoV-2. False negative results signify a RT-PCR test inability to detect the virus in a person who is having active infection. So what the hospitals are doing, how they are finding solutions? They are employing other tests like rapid tests, displayed results in few hours. RT-PCRs takes about 3 days to process or less. Antibody blood test helps determine whether a patient has an active infection or previously had an active infection. You have to combine all these tests with the RT-PCR so that you can reach whether this was a false negative. If the antibody was positive and is IgM positive, could be an active infection. IgG positive when the patient was having infection before, it could be COVID. And rapid is positive means patient is positive. So we have to combine all those tests along with the clinical findings, the symptoms, the history. They lead you to the, even if the patient is false negative, the history finding and the clinical symptoms, those are more important. Now, most polymerase chain reactions, that is PCR, antibody tests, have years of laboratory testing before they are used. I have already told you, just because the COVID came and there was massacre, so everything came so fast, including vaccine. So it has to be laboratory testing before they are used. Means years, it takes years to come about the kits and everything. So major concern for the false negative is someone who tests negative thinking they are not infected, could unknowingly spread the virus into the community. The WHO tells that a person with COVID-19 passed the virus who is positive to at least 2 people. So even if you are come out to negative, you have to isolate yourself so that you are not going to transmit the infection to the other persons. A person with symptoms receives a negative test should self-isolate. Many who are later diagnosed with COVID-19 and actually have been infected and spreading the virus for several days. So what you have to do is staying home and wearing cloth mask in public, especially when physical distancing is more difficult, will help slow the spread from those who might currently be asymptomatic but who are actually infected. The main diagnostic tests that are SARS-CoV-2 virus can have extremely false negative rates. Studies showed that the best day to get tested is the 8th day of infection, where 80% chances of positivity is there. Other diagnostic measures should be used in addition to the RT-PCR to screen for COVID-19. According to John Hopkins University report, the accuracy of the test peaks at 80% at day 8. Accuracy rates appear to be contingent upon the stage of infection, with the highest percentage of false negative reported in the first 4 days. I will show you the slide when people are often asymptomatic. If testing occurs on the day 8, chances are there, you will get the 80% chances are there, it is going to be positive. Usually 3 days after symptom onset, results are more accurate. Now, what they did, John Hopkins assessed data from 7 prior studies, which examined 1330 nasal swab samples taken from both hospitalized and non-hospitalized patients. The researchers then combined data from RT-PCR test to patient's history of COVID-19 exposure and onset system. So you see from there, day 1, false negative rates are 100%, day 4, 67%, day 5, false negative coming down to 38%, and day 8 is 20%, means 80% chances of positive test we can have. If you think that you have been exposed the same thing, the third, if you receive a negative result, you have to self-isolate. Now, coming to the, if you know the RT-PCR negative, what next can help you? So this data has been taken from Indian General Radiology 2021 January. Does CT help in reducing RT-PCR negative rate for COVID-19? Yes. In a pandemic setting, ground glass densities in a subpleural, posterior, and basal distributions are indicative of COVID-19. So CT chest in conjunction to the RT-PCR augments the diagnosis of COVID-19 pneumonia. Utilization of CT chest may just be missing link in closing this pandemic. Again, this study has been taken from this one, Huachan, chest CT of COVID-19 patient with a negative first RT-PCR test, comparison with patient with a positive RT-PCR test. So what it is telling, if you are COVID-19 patient, you are taking CT, in those cases, 43% cases, you will be getting ground glass opacities with consolidation, and 32% cases, because they studied 33 patients and 216 chest lesions were red. So in that cases, this data has been taken from this one on medicinal observational study, and he was the leading Hua Chen. So again, what they have seen, followed by ground glass opacities in first RT-PCR, and when the RT-PCR is positive, that case in 32% cases, you are getting ground glass opacities followed by ground glass opacities with interseptal thickening. So these are things, because you can be sure that even the chest CT can lead to negative RT-PCR, and that after that your chest CT can lead to the patient can be COVID positive. Again, this data has been taken from this published and the Yan Tang and Wenqi Zhang. Sensitivity of chest CT for the RT-PCR comparison to the CT chest with RT-PCR. You can see here 51 patients had evidence of abnormal CT, findings compatible with viral pneumonia at baseline. What were the findings? Same peripheral and subpleural ground glass opacities, often in the lower lobes, and 28% had atypical CT manifestation in this patient sample. The detection rate for initial CT, 95%, confidence interval 90% was greater than for the first RT-PCR. So these things have to be combined, and you have to see RT-PCR, the CORAD score is high, 4 and above, that patient can be still COVID positive. Treat the patient as a COVID positive, even if the RT-PCR is negative. Patient with the first negative RT-PCR test are higher inflammation markers even at the duration of 6 days after the symptom onset compared to patient with a positive first test. This is important. So in patients suspected COVID-19, the diagnosis must rely on RT-PCR test result, but also on the clinical presentation. I have talked already, and the finding from other like CT chest can be very helpful. So what we have, serial RT-PCR testing and the large use of CT scan must be rigorously evaluated so that we should treat the patient. Again, this study, it has been taken from the nature.com, predictors of negative first SARS-CoV-2 PCR despite final diagnosis of COVID-19 associated with outcome. Because what we have seen, markers are very high in these cases when the negative first SARS-CoV-2 is there. So you have to treat the patient with steroid and other things. That is important. And you have to do the serial RT-PCR, and this followed by CT. And then what to do and how to treat this patient. This is very important, because once you think that your patient is RT-PCR negative and 2 RT-PCR negative, 3 RT-PCR negative, 4 RT-PCR negative. We have seen one patient within our hospital, 4 RT-PCR negative, but the antibody was positive. We treated the patient with steroid, and the CT chest finding was CORAD score was around 5. So we took the advantage. We treated the patient with steroid. We also tried HFNO. and BiPAP, and we also gave remdesivir. So in these cases, you have to treat the patient aggressively with steroids, HFNO, BiPAP, low molecular weight heparin, remdesivir as per COVID protocol. And don't wait. In case of severe ARDS, if the patient has landed into severe ARDS, don't hesitate, intubate and ventilate the patient if the patient is not responding to HFNO or BiPAP. And in that case, consider early tracheostomy. Thank you.
Thank you so much, sir. It was really an informative session. Now I request Dr. Ankita to proceed the next session of the day.
Any questions?
No question.
Thank you, sir.
Simant, how are you?
Fine, sir.
So we are meeting on 31st.
Sure, sir. Sure, sir.
Anytime. Okay.
Sure, sir.
Dr. Nida?
Thank you so much. I welcome you all for the second thematic session of the day. This is Dr. Ankita. Chairing the second thematic session would be Dr. Sudhir Kunteta, intensivist and CMD Shubh Hospital, Jaipur. Dr. Vivek Badada, anesthesiologist from Pushpanjali Hospital, Agra. And Dr. Ankur Goyal, professor and head of Department of Microbiology, SN Medical College, Agra. May I request Dr. Sudhir Thantata to introduce our first speaker.
Hello.
Dr. Vivek can introduce the speaker since he's here.
May I request Dr. Vivek to introduce our first speaker of the session?
Dr. Vivek, please unmute. Please unmute yourself. Hello, Dr. Vivek, please unmute yourself.
Yeah. Hello. May I request to Dr. Seema Mehta? May I request to Dr. Seema Mehta to speak on the COVID during pregnancy observation and recommendation of obstetricians.
A very good afternoon to all. At the outset, I would like to thank the organizers for giving me this opportunity to interact with you all. I bring warm greetings from my institute, SMS Medical College, Jaipur. The coronavirus disease pandemic has caused a major impact on health systems worldwide. Obstetrics and maternal fetal medicine practices have suffered profound changes during this pandemic. There are aspects specific to COVID-19 and gestation that should be known by specialists in order to correctly diagnose the disease, classify the severity, distinguish specific signs of COVID-19 from those of obstetric complications, and take the most appropriate management decisions. Today, I will briefly contemplate specific aspects related to maternal fetal outcome in COVID-positive pregnant women on the basis of observations of various multicentric, multinational cohort studies. I will also highlight the recommendations made on the basis of these observations by scientific organizations and societies. Maternal and neonatal morbidity and mortality among pregnant women with and without COVID-19 infection. This is a study published in JAMA Pediatrics in the year 2020. This study was conducted in 43 institutions in 18 countries. A total of 706 pregnant women with COVID-19 diagnosis and 1,424 pregnant women without COVID diagnosis were enrolled in this study. It was found that a high risk of preeclampsia was seen in these women. There was high incidence of severe infection, intensive care unit admissions, the maternal mortality and preterm births were very high, severe neonatal mortality and morbidity, and severe perinatal morbidity and mortality was seen in these individuals. In this multinational cohort study, the conclusion was drawn that COVID-19 in pregnancy was associated with consistent and substantial increase in severe maternal morbidity and mortality and neonatal complications when pregnant women with and without COVID-19 were compared. Another study, update on characteristics of symptomatic women of reproductive age with laboratory confirmed SARS-CoV-2 infection by pregnancy status. This was published in Maternal Mortality Weekly Review on COVID in Pregnancy. In this study, it was found that the pregnant women with COVID-19 positive were at high risk of severe outcome compared with non-pregnant women. These findings might be related to the physiological changes of pregnancy, including increased heart rate and oxygen consumption, decreased lung capacity, shift away from the cell-mediated immunity, and increased risk for thromboembolic disease. In this study, it was also found that the pregnant women aged more than 35 to 44 years were nearly 4 times as likely to require invasive ventilation and twice as likely to die than were non-pregnant women of the same age group. Another study published in Lancet, the study was, were pregnant women more affected by COVID-19 in the second wave of pandemic? Yes, the pregnant women and the peripartum women experienced more severe illness in the second wave of COVID-19, and this was probably because of the emergence of the new variant of the coronavirus. Now I will address to some of the issues related to COVID positive pregnant women. Are pregnant women more susceptible to COVID-19? Yes, but the evidence suggests that pregnancy does not increase the susceptibility to SARS-CoV-2 infection, but appears to worsen the clinical course of COVID-19 compared to non-pregnant females of the same age group. The pregnant women are not at increased risk, but certain conditions like heart disease, diabetes, hypertension, asthma, obesity, and immunocompromised conditions like HIV and SLE, there is an increased risk of complications. Infected women, especially those who develop pneumonia, appears to have an increased risk of preterm birth and possibly cesarean section, and these preterm births are usually iatrogenic. Evidences suggest that frequency of miscarriage is not increased above the baseline in COVID positive women. Data on the first and second trimester infections are, however, limited. A meta-analysis on observational studies of SARS-CoV-2 infection during pregnancy found a 62% higher odds of developing preeclampsia among infected patients. Patients with asymptomatic infections appear to have a similar outcome as those without COVID-19 diagnosis, except the increased risk of preeclampsia, preterm delivery, and cesarean section. But the risk of adverse pregnancy outcome is increased in symptomatic patients, especially those with severe critical disease. Now, something about the fetal outcome. An increased risk of congenital anomalies has not been reported in COVID positive individuals. Similarly, the stillbirth rate and the intrauterine fetal death rates have also not been found to be increased in COVID positive individuals. No definite evidence that SARS-CoV-2 crosses the placenta and infect the fetus has been found. Now, I would like to share my experiences at Mahila Chikitsalaya, which is a COVID dedicated hospital for pregnant women in Rajasthan. During the first wave, 851 COVID positive women were admitted in Mahila Chikitsalaya during a span of almost a year. And in the second wave, which was a span of about 2 to 3 months, 398 women were admitted to Mahila Chikitsalaya. In the first wave, 77% women were on room air and only 23 required respiratory support, whereas in the second wave, 40% women were on room air and 60% women required respiratory support. About 6 women passed away due to corona in the first wave, whereas the mortality in the second wave was seen in 32 women, and there was 1 neonatal death. The mortality in the second wave was 11 times that of the first wave. Now, the data from the NICU of Mahila Chikitsalayah, about 173 babies were born to COVID positive mothers in the second wave, of which 7 babies were COVID positive, which was probably due to post-delivery exposure of the babies. There was 1 neonatal mortality. Now, the peculiar observations that were made during the second wave was most of the women were elderly gravidas, that is, the age was 32 plus years. 80% mortality was seen in women in rural areas. Approximately 30% pregnant women died within 24 hours admission to the hospital. And the bridge of mortality was seen in women presenting in the third trimester, and comorbidities was associated in 19% pregnant women. Possible causes of high mortality during the second wave was there was a long period between the onset of symptoms and admission to the hospital. Most of the patients were referred from the rural areas, and probably the inadequate respiratory and hemodynamic support during the transportation was responsible for it. The high mortality was seen in women who had oxygen saturation less than 70% at the time of admission. Pre-existing anemia and associated comorbidities was an important cause of high mortality. And most of the patients presented in the beyond the window period of injection remdesivir. Now, on the basis of the observations, various guidelines and recommendations were laid down by various scientific organizations. So these recommendations are: the pregnant women should be counseled about the increased risk of severe disease from SARS-CoV-2, and the COVID-appropriate behavior should be adopted stringently by the pregnant woman and her family members. The antenatal visits should be kept to the minimum, and wherever possible, the telehealth to deliver the antenatal care should be used. Regarding hospitalization of the COVID-positive women, it should be determined by the illness severity, underlying comorbidities, and the clinical status of the pregnant woman. And if hospitalization is indicated, the care should be provided in a facility that can conduct maternal and fetal monitoring. A multi-specialty team approach should be used. Saturation to more than 94%. No evidence that epidural or spinal analgesia or anesthesia is contraindicated in presence of coronavirus. However, epidural analgesia is recommended in labor to minimize the need for general anesthesia if urgent delivery is needed. COVID-19 is not an indication to alter the route of delivery. Cesarean delivery, however, would increase the maternal risk and would be unlikely to improve the newborn outcome. So the timing and mode of delivery should be dictated by obstetric indications rather than maternal diagnosis of COVID-19. During critical care admission, the oxygen should be capped at more than 94%, and hourly respiration monitoring should be done. Chest imaging, especially CT chest, is essential for evaluation and should be performed when indicated and not delayed due to fetal concerns. Pregnant women who meet the criteria for the use of glucocorticoids for maternal treatment of COVID-19 can receive standard doses of dexamethasone. And for fetal lung maturity, the usual dose of dexamethasone, that is 4 doses of 6 milligram 12 hourly, should be administered, and it should be continued to complete the usual course of treatment of maternal COVID-19 for 10 days or until discharge, whichever is shorter. The use of COVID-19 therapeutic agents during pregnancy, like antiviral therapy, anti-SARS-CoV-2 monoclonal antibodies, and immunoglobulin G products should not be withheld in the setting of pregnancy. The prophylactic dose of anticoagulation is recommended for pregnant patients hospitalized for severe COVID-19. The pregnant patients with COVID-19 who are asymptomatic and mildly symptomatic and hospitalized for other reasons need not require anticoagulation. The decision regarding anticoagulation in the pregnant women and postpartum patients should be individualized. Non-steroidal anti-inflammatory drugs and acetaminophen should be used with caution for treatment of fever and pain during pregnancy and postpartum period. The lowest effective dose should be used for less than 48 hours. The low-dose aspirin for prevention of preeclampsia is safe throughout pregnancy. In patients with abnormal liver chemistries secondary to COVID-19, acetaminophen should be used with caution. In WHO study, breast milk samples were taken from COVID-positive mothers, and all the samples were found negative for SARS-CoV-2 by RT-PCR. Hence, breast milk is safe for the baby. Should the mothers of COVID-19 be separated for the babies? Only for a short duration, yes, in severe illness. And during temporary separation, mothers should be encouraged to express the breast milk. If a mother and newborn are roomed in and the mother wishes to breastfeed a baby, she should put on a face mask and practice good hygiene before each feeding. At other times, physical distance of more than 6 feet between the mother and the neonate is advised. Regarding vaccination, it is recommended for pregnant women rather than deferring vaccination until after delivery. There are reassuring data regarding the safety and efficacy of COVID-19 vaccine during pregnancy. Vaccination can be done at the same time as administration of routine vaccine such as tetanus, diphtheria, and influenza vaccines. During breastfeeding, COVID-19 vaccination is recommended rather than deferring it until after breastfeeding. Maternal COVID-19 antibodies induced by maternal vaccination can pass into the breast milk and may have protective effect on the infant. So to summarize, I would like to say for prevention, pregnant women should follow the same recommendation as for non-pregnant women, but COVID-19 vaccination for all pregnant women should be given as soon as possible rather than deferring vaccination until after delivery. Not increase the susceptibility, but appears to worsen the clinical course of COVID-19. Elderly pregnant women with comorbidities are at increased risk of complications, hence special care should be given to them. Maternal complications like preterm, preeclampsia, eclampsia, and LSCS increased incidence are found. Neonatal and perinatal morbidity and mortality are increased during COVID positivity. Use of glucocorticoids in maternal treatment of COVID-19 and for fetal maturity are recommended. For pregnant patients hospitalized for severe COVID-19, prophylactic dose of anticoagulation is recommended. Paracetamol should be the preferred antipyretic and anti-analgesic agent. Several agents are being evaluated for treatment of COVID-19, but with minimal or no information on safety of pregnancy. Hence, their use should be done with caution. Thank you for your patient hearing.
Thank you so much, ma'am, for this wonderful talk. May I request Dr. Sudhir Kunteta to introduce our next speaker?
Good evening, everyone. Our next speaker is Dr. Shrikant Sahastra. He is a director and head of the Department of Pulmonology and Critical Care, Medicover Hospital at Aurangabad. He is teacher for IDCCM and is examiner for IDCCM. He is associated with IACCM for a long. Now I hand over to Dr. Shrikant. He is going to speak on NIV optimization.
Hello, everyone.
COVID HTV.
At the outset, I would like to thank Dr. Narendra Rungta sir, the Critical Care Foundation and ISCCM to give me this opportunity. I will be talking on NIV optimization in COVID HDU. The locations where NIV is instituted can be either in ER, HDU, ICU, or even in the wards where trained staff are available for monitor. What is NIV? It is the ventilation of the lungs using technique which does not use endotracheal intubation. And these are a few gadgets which are used. As you can see that you have a ICU ventilator with the humidifier, the active humidification, and the ventilator with backup battery and apnea, and you can have a inspiratory limb and a expiratory limb. So the interfaces used here are either a NIV mask, which is a full face mask with cushioning and entrainment valves, and a nasal mask or a nasal mask again with a swivel, 360-degree swivel for the 360-degree rotation. Now the types of NIVs are either CPAP, pressure support ventilation, BiPAP, or NIPPV. And what does it exactly does is it will decrease the afterload, it will recruit the alveoli, by which it can decrease the elastic pressure, and by intrinsic PEEP it will decrease the threshold pressure. Overall, the most important point and the most important thing which it does, it will decrease the shunt fraction. The physiology of NIV can be, as I said, is one is decreasing the afterload, especially in heart failures. It will increase the alveolar ventilation. It will recruit the alveoli, the collapsed alveoli. By then, it will decrease the work of breathing. And of course, it will stabilize the respiratory muscles. How to initiate these modes on NIV and how do we start? So either you can start with IPAP or a pressure support of about 10 or 12 and a EPAP or PEEP of about 5 to 6 centimeters of water. So you start with a CPAP of about 5 to 8, then you go up to about 10 to 15 depending on the need, with a aim of tidal volume of about 7 ml per kg, respiratory rate of about 25, and patient should be comfortable. The mask which is held gently on the patient's face, try to start with a FiO2 of about 100% and then decrease it and titrate it for the target saturation of about 90% or more than that, and keep the peak pressures of less than 25 to 30. Now this is what the BiPAP is, IPAP or pressure support plus CPAP or EPAP. And it is the IPAP which is used for the patients with type 2 respiratory failure, where you increase the tidal volume, you increase the surfactant production by thereby decreasing the PaCO2. And both of this will result in decrease in the elastic pressure and the resistive pressure. So this is IPAP and pressure support which is constituted in COPD patients. Now we are talking about COVID. So what are the indications of NIV in COVID? It is mainly mild to moderate hypoxemic respiratory failure secondary to COVID-19 and other indications which are given here. Most importantly, Professor Gattinoni, which has put forward the types of ARDS in COVID, the type 1 or L type, where the lung volume is less, the lung is light with less shadows, and the type 2 or H type, where you have less of lung volume with more shadows. And classically, NIV is to be constituted in the type 1 of the COVID-19 pneumonia or ARDS. What does the CPAP does? It actually uses the entrained oxygen in patients with low FiO2 requirement of less than 0.4%. And the patients which are comfortable, usually in the early phase due to the normal lung compliance. So you have to remember, you have to institute or use NIV in the early phase. Now what does this setting of NIV states is the separate inspiratory and expiratory circuits with a fixed exhalation walls, which helps to decrease the aerolization, and the synchrony and the comfort which is given by the NIV due to the spontaneous modes. Only thing is we cannot deeply sedate this patient, and we can use the ICU ventilator for NIV. The conventional BiPAP machine, which can also be used, but with one circuit. Helmets which are used as compared to the oronasal mask, wherein you keep inspiratory and expiratory settings which are kept about 50% more with fast pressurization rate. So classically you start with PEEP of 8 to 12 and a pressure support of 12 to 20. What does helmet do? It will decrease the droplets. It allows the patient to talk, read, drink. It prevents the skin necrosis, gastric distension, eye irritation. It acts as a reservoir with high inspiratory flows and shorter inspiratory times. And importantly, it can deliver high PEEP. But it will cause high PCO2, which is a disadvantage, along with the loud noise. It can cause asynchrony, more efforts, and the tidal volume, which is not guaranteed. But it may reduce the risk of death and the intubation rate, where in one study it has shown that it can reduce intubation rate as low as 16% versus 81% for the standard oronasal mask. The evidence for NIV by European Society and American Thoracic Society made no recommendation for or against the use of NIV during this pandemic due to the insufficient evidences. But they have stated that the trial of NIV could be considered in these patients, and of course further research is required. There were a few observational studies which showed NIV or CPAP may stabilize the clinical course of these patients, especially in mild to moderate respiratory failure. Mild to moderate respiratory failure. Another evidence is about the NIV says that initial NIV has been associated with significant survival benefit, and the mortality rates are almost identical to those who need invasive mechanical ventilation later in the course. And this is the paper, American Journal of Emergency Medicine, from Jan 2021. What are the contraindications of NIV? The one who had or who has upper respiratory airway obstruction, those who cannot handle the oral secretions, so there's chance of aspiration, patients with acute severe asthma or with pneumothorax, Glasgow Coma Scale of less than 8 or hemodynamic instability constitutes contraindications for NIV. And these are the complications. So the masks or the interface can give rise to nasal necrosis or nasal bridge necrosis with increase in the intraocular or intracerebral pressures, with extreme dryness of mouth. As I said, there could be chance of aspiration. The patient can have discomfort or intolerance, with hypotension because it's a positive pressure, and of course with gastric distension. And not to forget to mention about SILI, or self-inflicted lung injury. Now, how you need to monitor these patients while on NIV? You need to be at the bedside of the patient, observe their respiratory rate, check the ABG, and adjust the CPAP and pressure support to when it improves the SpO2 and lowers the respiratory rate. You can use small doses of sedation, and of course never forget to put a nasogastric tube to decompress the stomach, and later on feeding if required. So what are the endpoints of NIV responsiveness? When you see that there is a clinical improvement with the respiratory rate which is coming down, heart rate coming down, pH getting improved, with saturation also getting improved, there is coordinated muscle movements with the more and more comfort of the patient, and of course decreasing the shortness of breath. Now, when to discontinue NIV? Of course, when you see no improvement in oxygenation, when you see a hemodynamic instability with arrhythmias and intolerance, you need to quickly go ahead and intubate these patients. In the process of using NIV, how we need to protect our healthcare workers is of utmost importance. And WHO recommends use of adequate PPE during the use of NIV. While using a CPAP via oronasal mask or NIV with a helmet, we need to make sure that there is an inflatable neck cushion which is used to allow minimum room air contamination. This is done with a room or a cubicle with a negative pressure with 6 air exchanges per hour. And if there is no use of negative pressures, then at least use of HEPA filter. There has been studies which showed the affection of healthcare workers to the tune of 3.8% in Chinese studies and to the tune of 14% in few of the Italian studies. Now, what are the cautions which are to be used? NIV was associated with higher ICU mortality when the PF ratio was less than 150. So make sure that the patient's PF ratio is more than 150. Wait for 1 or 2 hours after the institution of NIV. And if the patient is not responding, then of course you need to go ahead with invasive mechanical ventilation. In that particular scenario, don't waste time. This is one way to prevent contamination, is to use a filter between the Y-piece and the mask. So talking about the use of NIV or CPAP, you could see that after the initial oxygenation, go ahead with CPAP with helmet or NPPV with face mask. If the patient doesn't improve, wait for another 30 minutes, give a trial of NPPV or NIV for another 1 or 2 hours. And if the patient does not respond, as you could see in this particular slide, you need to straight away go ahead and intubate this patient. So in conclusion, I would like to say that particularly in COVID patients, we need to use an NIV in mild to moderate acute respiratory failure. Wait for no more than maximum of 2 hours. If there is no improvement on NIV, please go ahead and intubate this patient to deliver invasive mechanical ventilation. Try and use helmet as an interface to minimize the droplet dispersion in ICU cubicle with a negative pressure chambers, and close the patient door when the patient is provided with NIPPV. There has been recommendation of keeping a distance of about 6 feet, but if it is feasible, then use it. Otherwise, you need to actually stick to the basic infection control policies. Thank you very much.
Thank you so much for an informative talk, sir. Now, may I request Dr. Ankur Goel to introduce our next speaker? Dr. Ankur Goel, please introduce the next speaker, sir.
Yeah. It is my proud privilege to welcome Dr. Sankalp Vanjara. He is Senior Consultant and Head, Critical Care Medicine, Sterling Hospital, Rajkot. Welcome, sir. Dr. Sankalp Vanjara.
Good afternoon, everyone. First of all, I thank you for inviting me on this platform to discuss about COVID and critical care. My subject today is non-mucor fungal infections in COVID ICU. Well, we all know COVID-19 has been a very aggressive respiratory viral infection. While most of the infected individuals have mild symptoms or they may be asymptomatic, but the few of them who develop moderate or severe disease, they really develop bad lung involvement, leading to hypoxia and hospitalization. Many patients die, but those who are survivors, they have a prolonged illness with a protracted course of recovery and punctuated by so many complications. Infections are one of the common complications seen in COVID-19. Well, bacterial infections are quite common. It could be pneumonia, UTI, and other healthcare associated infections. We also see viral infections like herpes. But fungal infections have been remarkably common in COVID-19 patients compared to other critically ill patients which we see in our critical ICU. Candidiasis, aspergillosis, and mucormycosis have been very common in such patients. Now, they were most commonly seen in symptomatic and hospitalized patients. We rarely see such fungal infections in those COVID-19 patients who have not been admitted, who had a mild illness and were just OPD patients. There were some common predisposing factors like immunocompromised states, diabetes, chronic kidney disease, chronic liver disease, chronic lung disease, and even immunosuppressive therapy. The fungal infections which developed in COVID-19 patients were usually during the second or third week of illness. If the patient had a really protracted course of illness and hospitalization, they could be seen even in the later stages. Why fungal infections are common? Well, the contributing factors has been an immunocompromised situation. We all know COVID-19 itself suppresses the T cell functions and even other immune functions of the body, leading to an immunosuppressed state. In addition to this, we have to use steroids. We sometimes use other immunosuppressive drugs like tocilizumab, other IL-6 inhibitors, JAK2 inhibitors. So these drugs also cause an immunocompromised situation. Patients with severe lung involvement usually catch up the fungal infections quite easily. And in addition to this, use of broad spectrum antibiotics not only predisposes to resistant bacterial infection, but also raises the incidence of fungal infections in some patients. So these are the contributory factors which lead to increased fungal infections which we see in COVID patients. Well, candidiasis is the commonest fungal infection which we have observed. Most commonly, it is the oropharyngeal site or the esophagus and even tracheobronchitis. Rarely, systemic candidiasis we've seen in really critical ill patients, and those who had been operated for some reason, They also develop peritoneal candidiasis. Candiduria, we all know, is common if catheterized, but it was also seen in non-catheterized patients. The commonest species were albicans and tropicalis. Luckily, we had very less incidence of other aggressive species like Glabrata, cruzi, or parasilosis. They were usually seen in patients with prolonged stay and on prolonged ventilator support. Diagnosis of Candida infection is not different in COVID-19 patients. You have to examine clinically for any upper airway candidiasis. We may use the scoring criteria for suspecting Candida infection, but we need to keep a high index of suspicion. Sending throat swabs, sputum, secretions, and blood cultures for microbiology were very helpful. And even if you grow Candida on sputum, you have to think of tracheobronchitis or even oropharyngeal candidiasis, which could be picked up in the patient's sputum. Role of BDG levels is the same as routine. We have a high negative predictive value for invasive candidiasis, but a positive BDG, we don't know what criteria what cutoff we should use to diagnose an invasive candida infection. And it has a low specificity because it is a common antigen found in other fungal species also. Treatment of all candida, first choice is azoles, and then echinocandins if the patient is really sick. Fluconazole has been our first drug of choice, but we were giving it in high doses because we didn't want the patient to worsen in an immunocompromised situation. Caspofungin and anidulafungin were used in critically ill septic patients or those who have deep-seated infections like peritonitis. In many cases, we need to use voriconazole to cover Candida and Aspergillus both because sometimes we are not sure whether patient has which of the fungal infections. So when you have suspected dual infection, we can use voriconazole. Well, clinical outcomes in Candida infections in COVID ICU we have seen were very good. Most responded well to antifungal therapy. Development of resistance was very rare. Life-threatening systemic candidiasis was very lethal. It was uncommon but had a very poor outcome. We also seen upper GI candidiasis which compromised the compliance of the patient with NIV because of severe throat pain and severe esophagitis, tracheobronchitis. Patient would not tolerate the NIV and that also led to a different outcome. So candidiasis, picking up candidiasis early is very important. I had made a routine of examining the oral cavity of my COVID patient every second day so that I would pick up candidiasis early and start treating it before it worsens and also hampers patient's treatment. Well, Aspergillus has been another common fungal infection. It has been documented very well in literature now that Aspergillosis has a high incidence in COVID-19. Pulmonary involvement was most common, but we also see occasional cases of invasive sinusitis and even a fungal ball in the maxillary sinus. Once we had that outbreak of mucormycosis, we started doing sinoscopy and debridement in patients who had sinusitis and where we are suspecting invasive fungal infection. I would say 8 out of those 10 patients would be getting mucormycosis, but 2 out of those 10 patients would also show aspergillosis instead of mucormycosis. So aspergillus is a quite not an uncommon invasive fungal infection of the sinuses in COVID-19 patients. Rare cases of stomach ulcer and even ileocolic involvement we have seen in our practice, and skin, brain, and eye involvement has been reported in literature, but I have not seen personally in my COVID ICU so far. Diagnosis is based on clinical features, but there is a huge overlap with COVID symptoms. Patients of aspergillosis also have chest pain, coughing, fever, and hypoxia. And these symptoms are there in our hospitalized COVID-19 patients. So it's difficult to differentiate whether it is because of COVID or because of some invasive fungal infection like aspergillosis. So we have to keep a high index of suspicion. If the counts are rising, the CRP is rising, and you feel it is some secondary infection, then you should remember that it could be aspergillus rather than a bacterial infection. The other differentials in such COVID patients are usually primary disease progression of the COVID itself. It could be a beginning of a cytokine storm, it could be a thromboembolic event in the lungs, it could be CCF because of myocarditis, and it could also be a secondary bacterial infection. And in patients who present late in the post-COVID state, I would say third or fourth or fifth week, we would also think of tuberculosis. So these are the differentials which we should keep in mind. Well, HRCT thorax is not very sensitive for diagnosing Aspergillus in COVID-19 because there are so many radiological abnormalities due to COVID itself, which would mask actually development of classical Aspergillus radiological findings like nodules or cavities. A suspicious radiological picture, classical of Aspergillus, is quite uncommon, and if it comes, it's really late in the course of the disease. We have to diagnose Aspergillus. Well, peribronchial infiltrates and patchy consolidations may sometimes raise the suspicion, but otherwise we have to rely on to keep a high index of suspicion and diagnose Aspergillus on some other criteria. Pulmonary nodules and cavities present are quite late in the course of illness. Lab tests which I do is to send a procalcitonin and blood culture to pick up a bacterial infection, do IL-6 and ferritin to rule out a cytokine storm, T-dimers, of course, for thrombosis or a cytokine storm, rule out cardiac illness, cardiac complication with troponin and anti-proBNP, and do a 2D echo biopsy. Simultaneously, we should send galactomannan and beta-glucan. Well, galactomannan, although it is a specific marker for Aspergillus, it is also seen in some other fungal infections. It is also seen with use of pipratezo, with use of IVIG, and even with transplant background. So it is less sensitive, it is specific, but still it is not foolproof. And beta-glucan, which is also seen in Candida, PCP, and other fungal infections, so it is also not a specific marker. But raised level of these markers would raise a suspicion for Aspergillus or other fungal infection. Well, microbiological diagnosis is important. You can send sputum or bulk for microscopy, antigen testing, PCR testing, and also visualize the bronchus endoscopically. You can have a histopath or biopsy sample for diagnosing invasive fungal infection. Other fungi, Pseudomonas tuberculosis, are differentials. A single test is never enough to diagnose invasive aspergillosis. You need to combine all these tests plus the clinical background to diagnose. Well, the drug of choice is voriconazole, and you may need it for a 3 to 6 weeks duration or even longer. Other drugs, when voriconazole is contraindicated, like POSA or isavuconazole or inidulafuncin as a combination therapy. Amphotericin can be used as a broad spectrum therapy when you are not sure which fungus it is, or even as a salvage therapy. Last, then I would discuss a case, Mr. Patel, who was admitted on 15th April in the second wave with a very prolonged critical illness, even TOSI, put on NIV and HFNC in ICU, 40 days in ICU, he had a persistent O2 requirement. He developed maxillary sinusitis and endoscopic drainage was done, and which showed a Aspergillus fungal bowl which was non-invasive on histopathy. However, I had a suspicion on the basis of clinical picture. CT scan was not showing anything, so I started him on preemptive oral voriconazole. Was discharged on 6 June. And on follow-up, he showed thick walled cavities on the CT scan, which again resolved. So, although first CT scan was not showing any cavities, because of the clinical background, I started voriconazole, and I was happy that I did it because the patient started improving as treatment was started early. So, to sum up, I would say for good outcomes in COVID, you need to have a high index of suspicion for diagnosing fungal infections. If you start the treatment early, you can have good prognosis. If you start late, then you may lose the patient, and preemptive therapy may be needed. So thank you all. Thank you for the patient listening. I hope I have been in time. Thank you.
Thank you, sir, for this comprehensive talk. May I ask Dr. Vivek to introduce our next speaker?
Hello. May I request to Dr. Reshu Gupta to speak on the COVID encephalitis difficult customer. She is HOD and critical care medicine in the Health City Hospital, Guwahati.
Hello all. So today my topic of discussion is COVID encephalitis. So why are we discussing this topic today? Because encephalopathy and encephalitis, we have seen it is now coming up as a major and devastating CNS complications in patients with SARS-CoV-2 virus associated infected patients. SARS-CoV-2, we know it's a widely recognized as a respiratory pathogen, but neurologic complications can be the presenting manifestation in a subset of infected patients. The first such case of meningitis associated with SARS coronavirus 2 was published in Feb 2020. This was a case from Japan, a 24-year-old man who presented with headache, generalized fatigue, and fever. He consulted a doctor nearby and he was prescribed some antivirals and antipyretics under the diagnosis of influenza. 3 days later, he had to visit another clinic because of worsening of his symptoms. He underwent X-ray and blood tests, which came out to be negative. On day 9, he was found unconscious lying on the floor. And during the transport to the hospital, he had multiple episodes of generalized seizures. So this was the presentation which was missed, which was delayed. Then subsequently, there have been few other cases also, like, for example, this gentleman of 31-year-old man, COVID-19 positive patient, he presented with acute behavioral changes, severe confusion and drowsiness, and severe agitation. All the cranial examinations and the other neurological examinations were negative, more or less normal. His other chest examination, abdominal were also normal, except that his CSF was found to have viremia with SARS-CoV-2 RNA-PCR positive. Also, one interesting finding was that was found in his CSF was that he had significant RBCs in his CSF. Otherwise, his proteins were normal, glucose and other viruses were negative. Henceforth, there have been few other cases like Ashim Heather et al. They reported a case of acute encephalitis as a clinical manifestation of COVID-19, where the hallmark feature they had seen was altered mental status. Even in my unit, we have a data of 4 such cases who presented with fever, vomiting, altered sensorium. The inflammatory markers were positive. The D-dimers were all high. Procal was high in such cases. His CSF, all the CSF findings were more or less normal, except for in 2 cases we got significant RBCs. Unfortunately, all the 4 CSF samples were tested negative for SARS-CoV-2 virus. CT findings were significant, were positive. We will be discussing the neuroimaging in my subsequent slides. Unfortunately, we could discharge all the 4 cases healthy. So in 2020 June, Garg et al. They did a review of all these published reports and they performed an extensive research of PubMed, Google Scholar, Scopus. They identified all the case reports, case series and cohort studies. They analyzed the demographic, clinical, CSF and neuroimaging characteristics of these patients presented with COVID-19 associated encephalitis. Also, they discussed the pathogenesis associated with encephalitis and COVID-19. Again, in 2021 May, Xiao et al. They did a meta-analysis and systematic review of all the published data from 1st November 2019 till 24th October 2020, who reported, who developed encephalitis as a complication of COVID-19 only were included. The cases with radiological or biochemical evidence of encephalitis were included. So these were the different studies they had included. There were case series and cross-sectional studies as well from different parts of the world. So they came to the inference that the time from diagnosis was around 14.5 days in average. The average incidence of encephalitis as a complication of COVID-19 was 0.21%, which increased to 6.7% if the patients are severely ill with COVID-19. The mortality they had seen was quite significant at around 13.4% in these cases. Among the demography, as I had shown in my previous slide as well, that mean age was around 60 years. Males were equally affected as females. One interesting finding what they got was there was at least presence of one comorbidities which was seen in almost more than 70%. Hypertension being the most common, followed by hyperlipidemia, diabetes, chronic kidney disease, liver disease, and congestive cardiac failures. The clinical features, the patients usually presented with the common COVID symptoms of respiratory symptoms like cough, fever. Very few patients had presented with CNS manifestations like confusion, agitation, delirium, or coma. Myalgias, headache, and other non-specific symptoms were also present. In 20% of the patients, they were found to be unconscious, with altered consciousness, and seizures and status epilepticus were also a manifestation. So they propose basically three pathophysiological mechanisms. First, there is direct invasion of the nervous system, which we will be discussing in subsequent slides. There is systemic inflammation as seen in the cytokine storm, where they found the raised inflammatory markers in the CSF as well. And third is the molecular mimicry. So this is the direct invasion of the CNS system. This direct invasion is the direct entry of the virus into the neurons via the transsynaptic propagation or direct to the brain parenchyma, where they use the ACE2 receptor. It facilitates the entry of this virus into the cells. We know that the SARS-CoV-2 virus is a single RNA genome. It is an envelope. It is inside an envelope, and the spike glycoprotein, they have a special affinity to this ACE2 receptors, which helps the entry of these cells into the cells, this virus into the cells. This spread is either from the olfactory epithelium, also to the respiratory epithelium, or through the hematogenous propagation via the vascular endothelium. Then the molecular mimicry, it is post-infectious encephalitis. This is an autoimmune demyelinating disease of the brain triggered by the SARS-CoV-2 virus. This immunological response to the virus, it reacts with the myelin autoantigens, resulting in post-infectious encephalitis. Interestingly, this is the most common encephalitis in COVID-19 we have seen. They present with acute hemorrhagic necrotizing encephalopathy or GB syndrome or ADEM. So we see the route of entry is direct invasion of the neurons and the endothelial cells, so the olfactory symptoms, the retrograde travel by the axonal transport, so the blood-brain barrier through the vascular endothelium, and also through the infected leukocyte migration to the blood-brain barrier. Also, we know this mechanism is known as the Trojan horse mechanism. So the neuroimaging, this is a neuroimaging picture which has been reported in the Journal of Medical Virology. They show in the MRI some hyperintensities in temporal lobes. Also, there might be microbleeds and hemorrhagic lesions in the thalamus. So these are the different pictures which I've collected. This is a CT scan showing hypodensities in the bifrontal lobes. This is an MRI showing the hyperintense signals seen in the temporal lobe and also the diffusion restriction in the parasagittal frontal lobes. This was a case reported of acute hemorrhagic necrotizing encephalopathy in the Radiology Journal, where they had seen that in MRI, it reveals hyperintensity in the bilateral medial temporal lobes as well as the thalamus. The EG is seen more or less normal, except few patients, they had few generalized delta activity. Otherwise, there were no anomalies present in the EG. So if you come to the treatment is generalized ICU care and treatment. Basically, the treatment, the proper ICU care and treatment, inclusive of ventilation and other supportive measures, were good enough. But there have been few case reports where they have used corticosteroids in COVID encephalitis, which have shown positive results. Even intravenous immunoglobulin has been used. Plasmapheresis was also used, and it was published by Dogan et al., where they had a case series of 6 cases. Out of those, 1 case succumbed to death and 5 successfully were revived. Use of monoclonal antibodies such as rituximab were also been seen. Prognosis: if the patients have some neurological disease along with COVID, the death rates are higher, delirium is higher, then there may also be greater disability. But majority of patients improved following ICU management. So to summarize, if you see, the age group is basically more than 50 years, unlike our scenario in my setup where out of 2 patients were of more than 50, but other 2 were below 50. Duration of illness, 5 to 14 years, more or less same. Initial symptoms are fever, cusp, dyspnea, anosmia, and ageusia. Peculiar clinical neurological manifestations are headache, vomiting, and altered sensorium, ranging from altered behavior to seizures to even coma. Blood parameters, except for lymphopenia and thrombocytopenia, others were normal. Biochemical parameters, they were elevated. Inflammatory markers like procalcitonin, interleukin 6, ferritin, CRPs. CSF changes, largely normal, except for some findings, positive inflammatory markers. Neuroimaging, as already described, there were periventricular signal changes. Outcome, patient often need ICU care. So to conclude, we know that COVID-19 is primarily a respiratory pathogen, but there is an increasing evidence of it in both the central nervous system as well as peripheral. It is basically a disease of exclusion, as there are no specific findings seen on the EEG, CT or MRI and CSF analysis. Although the incidence is low in hospitalized COVID-19 patients, but mortality is significantly high. And also the incidence increases in severely ill COVID patients. So we need collaborative international registries which would help us to comprehensively decipher the pathophysiology and prognosis of encephalitis and COVID-19 and thereby help us in improving the effectiveness of the care. Just at the end, to add as a humor, this was a case report published in Quack Doses by Dr. Mohit Garg, where the nurse had spot diagnosed encephalitis after returning pain to the system. I would request all of you to go through it. Thank you, and I'm ready for any questions.
Thank you so much, ma'am. The session is now open for question and answers.
I think there are no questions from anyone.
Sir, if I'm allowed to ask.
Yes, ma'am.
Dr. Khuneta, if I'm allowed to ask, I wanted.
Yes, proceed.
Yeah, I wanted to ask Dr. Seema if she is there regarding pregnancy and COVID.
Let me see. I think Dr. Seema is logged out.
Okay. So my question was regarding the steroid for the patients which she had used, because like if the pregnant patient have come with requirement of oxygen or ventilation, then which steroid did she prefer? And for how long did she continue? And secondly, the question was like remdesivir, because we also have few data. So remdesivir did she use in all the patients? or she did not?
As you
I don't think
mentioned,
so. She's there.
she's not there. But regarding remdesivir, it should be used as for the general population. If there is no separate criteria prescribed for the pregnant woman or non-pregnant. So if patient is fitting in the remdesivir windows and other, it should be used. For the steroid use, I don't know what she used and she has not elaborated it.
Okay, sir. Thank you.
So I thank all the esteemed chairpersons and the speaker for this very comprehensive session. With this, we conclude today's session for the day. And thank you all and hope to see you all tomorrow for the workshops. Thank you.
Thank you very much.
ये ठीक है ऋषभ, थैंक्स।
Okay, ma'am.